Alrighty, everyone. So, this is our first in-semester revision lectures for semester two. We're going over upper limb, lower limb, as well as myo and neurophys. And then at the end, so around 1:30, Raman's going to have a Kahoot on a bunch of questions, just on upper limb and lower limb. So, so stick around for that. And it might go a little bit beyond two. So it's up to you guys if you really want to stay the whole time for the Kahoot, but should be worth it. All right, let's jump into our first revision lecture, which is upper limb. And that is my revision lecture. So upper limb is a really dense topic, everyone. It's, anatomy, and so there's a lot to cover. And it's really unrealistic to sort of summarize everything within an hour. But that being said, there are a couple of really important stuff that I wanted to look at. So particularly in this lecture, we're going to look at the bones really briefly, have a look at the muscles, the brachial plexus and the nerves, and then go on to look at a little bit of vasculature and spaces. Vasculature is not that important, just have an idea. And then pathologies, which I would say is probably the most high-yield part of this lecture, trying to understand them. So stuff like any lymphatics, and also like the ligaments we haven't had a look at specifically in this lecture. And if you want to revise them, then have a look at that in your own time. And also, it's been a while since you guys have done upper limb. And so hopefully this is just a way to sort of refresh that stuff. If you guys have any questions as well, chuck it through the chat. I'll be monitoring that. And hopefully I can do my best to answer them. Okay, so let's jump into bones. Oh wait, let's do some thanks first. So quickly just thanking Jeffrey Shao for the 2020 upper limb revision lecture. Also the 2020 swap back revision lecture, just helped me guide with this one. One of my friends, Natasha, for helping with the slides, especially with the muscles. And then this is the only topic I actually really took notes on for semester two, which is kind of good. So I can give this revision lecture. Okay, so looking at bones, just a really quick overview. We should be familiar with all the bones in the upper limb. The clavicle, scapula, humerus, ulnar being on the pinky side, and then the radius on the thumb side, as well as our wrist bones. It's good to know the order of the wrist bones and exactly which one is which. And there's a bunch of mnemonics that you guys can help to memorize those. The one that I like to use is so long to pinky, here comes the thumb, because whenever I would use the other ones, I'd forget like where it starts. And so long to pinky just tells us that we start at the bottom and we go towards our pinky. And then we go to our second layer and we go from the hamate towards our thumb. So we can see all the wrist bones there. Another good way to check that you've done it right is the trapezium matches your thumb. And so if you end there and you're at your thumb, then you've done it right. And then of course our hand bones, which are just the metacarpals and the phalanges. So what should we know about the bones? Do we need to know every bony tuberance or every groove on the bones? No, we definitely do not. We should just keep an eye on sort of the big stuff, right? So know about your fractures. For example, clavicle fracture, your humerus fractures is a type of fractures, wrist fractures, know about your dislocation of your shoulder, know about like the important stuff. So for example, can anyone tell me what the radial groove is on the humerus? Someone remember what that is?
Where the radial nerve goes.
Yeah, perfect, right? So that's a pretty big one, right?
And profunda brachii.
Yeah, perfect. Profunda brachii. So those are things to keep an eye out for. Yeah, you don't need to be like 100% knowledgeable on every part of the bone. Okay, what is important though is our muscles. And there's a lot of stuff in muscles, right? But the attachments aren't the key part of muscles. It's a good idea to know where your muscles start, where they finish, but generally is often good enough. But knowing the specific attachment points and insertion points is not that important. What is important though is the innervation of our muscles, the compartment and so the action of the muscles as well, and any important clinical features. So the good thing about upper limb is that the muscles in the arm and the forearm are really sort of easy to learn in terms of compartmentalizing them. But the shoulder is a bit less like that. So let's have a look at the shoulder. So we can break them down into sort of three categories: the anterior muscles on the front, the posterior on our back, and then between the ribs and the scapula, or sort of deep posterior. Okay, looking at the anterior muscles. So what we've done is just summarized the muscles, action, innervation, and some clinical features. So we won't go through every muscle or the whole table today. But if you guys want to refer back to this or look at it in your own time, that's all good. But I'll just point out some important stuff. So with the shoulder muscles, it's hard to sort of compartmentalize, but if you have an idea of where the shoulder muscles start and go, then you can sort of figure out what they do as well. So with our pec major, we know it starts on our chest and then it goes, attaches through our humerus, right? And so if we think about that pulling action, well, it's going to do the adduction and it's going to do the medial rotation. And then we can see as well this flexion and drawing the scapula. With the pec minor, it's mainly stabilizing it. The important clinical one here is the serratus anterior, which, as we know, C5, C6, C7 winks to heaven. And so that's the one that's going to keep us a scapula with our ribs as well. And when that muscle isn't acting, we're going to get the winging of the scapula. Yeah. And then the subclavius, not really important, underneath our clavius or clavicle. And then it also protects from nearby neurovascular structures, within clavicle fractures. Okay. Now the rotator cuff muscles, these are important muscles. Why? Because we often see rotator cuff tendonitis. We see issues with rotator cuff. They're the most common injury. Do you guys remember which one of these muscles is the most common rotator cuff injury?
Supraspinatus?
Supraspinatus. Yeah, that does sound right to me. And if we can look at these muscles again, we can categorize them into the ones that sit on top of the scapula, back of the scapula, so posterior, and the one that sits anterior to the scapula. So there's a little mnemonic sits, with SIT being our supraspinatus, infraspinatus, and teres minor, which all attach to the greater tubercle, and they're all posterior to the scapula. And then our subscapularis on the inside of our scapula is attaching to the lesser tubercle. Okay, these are important as well, as I mentioned, just because of the tendonitis. Okay, looking at the posterior shoulder, again, they're not really easy to categorize in what they do. They do a lot of stuff. I think the main one here to take note of is the deltoid, and the degrees as well of abduction. So if you can categorize which muscles do which degree of abduction, that will help. More so in clinical skills and identifying which muscle has weakness. Okay. And then finally, some final few shoulder muscles. Again, these aren't that important. For the ones that are important, is mainly like the innervation for the serratus anterior. But having an idea of where these muscles are will help, and just having an idea of the action. What is really important though are all your arm muscles. And this is where it gets quite a bit easier in my opinion, because we can start to work in these compartments to understand actions. So if we look at our anterior compartment of our arm, those are all flexors. And then our posterior compartment, it's only one, it's going to be our extensors. And they're going to act on both the shoulder and the elbow. So looking at all the arm muscles, we have our biceps brachii, brachialis, cocobrachialis. These are all flexions of the forearm, as well as flexion of the arm. And they do have some other minor actions like supination and adduction of the arm, but they're not the main actions of those muscles. They're all innervated by the musculocutaneous nerve, really important to know. And that makes sense when we look at sort of where the musculocutaneous nerve goes. And then the brachialis as well has some minor innervation by the radial nerve in the lateral portion. And then the triceps brachii, that's on the back, so it's going to do extension of the elbow and weak extension of the shoulder, and that's radial nerve. If we know the course of the radial nerve, that goes posterior to our humerus, does the radial groove, and then goes on to innervate some things in our forearm. Yep, so those are the muscles of the arm. Just some diagrams to help us visualize them, to spark our memory. But the arm is pretty good. It's not too dense. The forearm, though, is very dense. The good thing about the forearms, though, is that we can really figure out what these muscles do by their names. It's got flexor in it, so it's a flexor. Carpi radialis, ulnaris. We can take a lot from the names. Does anyone remember the difference between the flexor digitorum superficialis and the profundus? Yeah, so just a good question in the chat about whether we need to know the nerve roots, for each muscle, or just the name of the nerve itself. So that's a good question. What is important with nerve roots is the myotomes, and so that's knowing what roots innervate what action. With the muscles, I would say that knowing the nerve is the most important thing, but if you can memorize the roots as well, that does help. The ones where it's tricky is like the median nerve and the musculocutaneous, because they have a lot of roots providing to those nerves and to those branches. and so it can be a bit hard. But stuff like the ulnar nerve, we know is just C8 and T1, and other ones have less sort of roots involved. So if you can, it's a good thing to do that when just memorizing the innervation, but it's not essential. What's more essential is the myotomes for each root, and that'll give you an idea of what muscles have what roots as well. Okay, so the profundus goes all the way to the fingers. That's right. We can't see it here. We can't really see it here either, but yeah, the profundus goes all the way to the fingers, all the way in the fingers, whereas the superficialis sort of splits off right before that. Okay, what slide am I on? Sorry. Okay, so let's look at the superficial compartment. These are mostly flexors of the hand, but they do have some light ones. If we think about the flexor carpi radialis and carpi ulnaris, we can sort of memorize that they're doing abduction, adduction, simply by their location. So radialis is going to be on our medial side, and so that's going to abduct our hand, take away, whereas our ulnaris is going to be on the pinky side, so that's adduction. And then the pronator teres, again, it's in its name, pronation of the forearm, and then since it's also in our anterior compartment, we can also assume that it does some flexion of the forearm. So all of these are the median nerve except the carpi ulnaris, which is good because that's the ulnar nerve, and so we can take from its name. This is just an image. One way that I sort of I got really confused between like the order of these superficial muscles, but just memorizing that from medial to lateral, lateral to medial, it's the it should be medial to lateral, I believe. Oh no, yeah, medial to lateral, starting from the middle, is our teres, then our radialis, then our longus, then our ulnaris, and then I just use this to help me memorize that. This rainbow longhorn unicorn, but yeah, medial to lateral, I believe. Okay, then intermediate compartment, that's just our superficialis, which as we said, only goes to the MCP and proximal interphalangeal joints. It does a little bit of flexion, naturally, because it crosses the wrist. And then the profundus, which, as you guys said, goes all the way to the distal interphalangeal joint. This one has split innervation, so it's median nerve, so it's the ulnar nerve and the median nerve. So our lateral part is the median and our medial part is the ulnar, which is not the most intuitive in terms of the name. Anyway, then we've got our flexor pollicis longus, our pronator quadratus. Again, it lies in the name. Flexes the index finger and is inside the forearm, which is why it's longus and not a brevis. Okay, again, just some visualization of those muscles. Now we're going to the posterior. Again, there's a lot of muscles here. But these are also sort of good because their innervation is shared. So our radial nerve innervates the brachioradialis, carpi radialis longus, and also the carpi radialis brevis. The extension digitorum, that's going to extend our digits, extends the digiti minimi, sorry. Again, that's our pinky finger extension. As well, since it's on the pinky side, it's going to contribute to some extension of the wrist naturally because it crosses it. And then finally, extensor carpi ulnaris. Again, same thing, but with the extensors. Now, these are all mainly radial nerve. Just one, it depends on if they're deep or if they're just a normal radial nerve branch. And that makes sense because the radial nerve goes on the posterior of our arm. Yeah, so alconius, not really an important muscle. I honestly forgot it existed until I came back to this stuff. So yeah, not that important.
Bhuvan, just
Yeah.
a question. Do we have to remember like posterior interosseous, anterior interosseous, or is just radial nerve fine for the purposes of?
So like if we think about the questions we sort of get, they're more about the, like, if we think about the upper limb, the really sort of high level questions we often get is not like what is the innervation of this specific muscle. It's more about when we damage a nerve root or when we injure a specific part of our arm, what's likely to happen in terms of our symptoms. And so you can go ahead and go to that level, but knowing that it's a deep branch of the radial nerve will help in figuring out those clinical presentations and those signs that you'll sort of get in your exam questions as well. So I wouldn't say it's like 100% essential. And I don't know if I don't think I really remember that fully, if it's the deep interossei nerve and stuff like that. But knowing that it comes from the deep branch of the radial nerve would be like that's probably good enough as well, if that makes sense. So not essential, but obviously knowing it is not going to harm you at the end of the day. Okay. All right. So again, just visualizing our muscles. This part of the notes, as I said, or slides are more for just to refer back to when you guys need it in a summary. It's hard to really get anything that concrete or high yield just from the muscles themselves. So again, now the deep compartment, again, we can see it's all in the names: abductor pollicis longus, extensor pollicis brevis. So that's how we should remember them essentially. Here we have the interosseous nerves, but again, radial nerve, so we know what injuries would happen. And then, yeah. Okay, hand muscles, these are a lot easier in my opinion. The thenar muscles, they all act on our thumbs, and then the hypothenar is the opposite, acting on our pinky, but they're all sort of the same actions and almost the same molar structure. And then we have the deep lumbricals and the interossei muscles, as well as some random other muscles. So thenar muscles, all of these are the median nerve. Again, all in the name, having an idea of where they are. So the opponent's pollicis, then the abductor pollicis brevis, and flexor pollicis brevis. And then on the opposite side, we will have the deep muscles of the hand. Oh, no, sorry, the hypothenar muscles of the hand, which are basically the exact same thing, but for our pinky. And so the hypothenar and thenar muscles are all about the fine movements of our thumb and our pinky, or our digiti minimi. But yeah, they're pretty easy to remember together. And then the deep muscles, lumbricals and the interossei muscles. The lumbricals is really important to note because it has split innervation again. The medial two have the ulnar nerve, whereas the lateral two have the median nerve. So if I remember correctly, there is no radial nerve innervation inside the hand. And so, well, for motor innervation at least. And so it's either the median or the ulnar. And it's sort of easy. Thenar side is median, hypothenar is ulnar, and then the lateral lumbricals are the median as well. And then these other muscles, palmaris brevis, really not important at all. I think that's not meant to say dorsal interossi. That is meant to say the adductor pollicis, sorry, which is an adductor of the thumb. Okay, now let's go on to this question. Which of the following muscles is least likely to be affected in the presence of an ulnar nerve lesion? So you guys can hop on in the chat or wherever. For the answer. What do you guys reckon? B?
B.
Yeah, B, good. So yeah, it is going to be the lateral two lumbricals. Because all of the rest of them are ulnar, while the lateral two lumbricals are the median. You guys might have heard of this half of half. Apparently it was like they keep stressing it in anatomy. And it's a good mnemonic to memorize the median nerve innervations. The half lumbricals, which are lateral lumbricals, the O for the opponent's pollicis, then the abductor pollicis brevis, and then half of the flexor pollicis brevis as well. Okay. Let's look at the brachial plexus and the nerves now. So this is our brachial plexus. It's the first thing you guys learn of, I think, inside upper limb. And it is pretty important. We should be able to draw this relatively off by heart, at least the roots, the trunks, the divisions, cords, and the terminal branches, as it will really help in our naming and our understanding of the nerves and the nerve roots. Also to note is the M landmark. I'm not sure if you guys ever got to see specimens for the brachial plexus or for upper limb, but the M landmark really helps to identify what nerve is what. And that's over here, if you guys can spot that, the M. Okay. So another version of this diagram that I personally like is this sort of cleaner diagram, and it sort of helps to understand it a little bit more. So let's take a quick look at each of these. Roots, these are really important, mainly because of the myotomes, the dermatomes. So one thing to note is it's not the actual spinal nerve roots, but just the ventral rami, so where the roots are coming from. And there are some important branches here, specifically long thoracic nerve, which, as we know, serratus anterior, and then the dorsal scapular nerve. So if we look at the dermatomes and myotomes, I'd memorize these by heart before your exam, at least. They'll really help with the muscles. Some people came up with like dances to memorize these that you can sort of do to figure out what root is for what. But in general, the higher roots are closer, more proximal, and more distal is our lower roots. And our dermatomes, again, similar, higher roots, and then we go down to our lower roots. Okay. As well, just a little point here about the injuries. Again, it's basically based on the myotomes and dermatomes. If it's in the top of the brachial plexus, it's going to be more proximal. If it's on the bottom, it's going to be more distal. So forearm and hand. All right, trunks and divisions. So superior, middle, inferior trunks. Again, some important branches to know. Important landmark as well is that these go between our scalene muscles inside the neck. And it's also just accompanied by the subclavian artery. As we can see here as well, the clavicle is quite nearby. And that's where our sort of divisions, our trunks, divisions, and then terminal branches happen. Okay. So looking at the divisions as well, we know that basically forms into our anterior and posterior part of our brachial plexus. Again, I think drawing this and memorizing how to draw it is the best way, but we should know which chords are supplied by which divisions. So that's being lateral cord is our anterior. Our posterior chords are just going to be our posterior divisions from all of the roots, from all of the trunks. And then finally, our medial cord is just anterior from our lower trunk, I think. Inferior trunk, yeah. Okay, branches, most important part of the brachial plexus are all of these branches. Remember, axillary nerve and the radial nerve are going to be our posterior nerves, whereas the rest of them are going to go to the anterior side. Really, really important to memorize this stuff. As we can see here, the median nerve, it sort of comes from all of our roots. It gets, some innervation from everything, almost. And so it's really important to know that. Ulnar nerve is only C8T1, and musculocutaneous similarly is only our top roots. Okay, so let's have a look at each of these. So looking first at the posterior stuff, we've got an axillary nerve. Important sort of buzzword is the shoulder patch region for sensory innervation, and muscles of note is the deltoid and teres minor. The radial nerve, again, posterior again, is going to innervate the posterior muscles, and it's also going to give us sensation of the lateral dorsum of the hand. So that's the back of the hand. Oh, and also really important, as was mentioned before, it goes to the radial groove of our humerus, right? Similarly, our axillary nerve, that's going to stay around our glenohumeral joint and then go towards the back. And so it's a good idea to remember the courses of these nerves, because that's going to help us figure out what happens when there's an injury or something like that. Okay, the anterior terminal branches now. We've got our musculocutaneous nerve, which is innervating all of our arm flexors and our lateral forearm sensation. And also our median nerve, which is the big one, innervates all of this half of half, if you remember. And also there's a superficial cutaneous branch of the median nerve, which does some arm and forearm innervation as well. Okay. One thing that I wanted to mention here that I didn't put on the slides is that the median nerve does sort of branch off, whereas the motor innervation for the median nerve goes through the carpal tunnel, but the superficial cutaneous branch of the median nerve doesn't. It branches off right before that, which is important to note for carpal tunnel. And we'll go back to that later. And then the ulnar nerve, again, we can see it's on our medial side of the hand. So that's the first 1.5 digits, the hypothena and the third and fourth lumbricals. Okay, great. So a question, just to try and actually take something from those nerves. If I have a pancreas tumor on the apex of my lung, so that's like right up here, which is growing and it's pushing up obviously onto my shoulder region or clavicle region, what clinical presentation am I likely to have? Oh, sorry, I closed the chat by accident. A, yeah, that's really good. So we are going to have an ulnar claw. So this is basically just knowing what our myotomes are and knowing our myotomes. And we know the ulnar claw is supplied from the bottom here, looking at finger flexion abduction. So if the tumor is growing and it's hitting the bottom roots of my brachial plexus, that's what's going to be damaged, and that's what's going to be interfered with. And so we're more likely to present with ulnar claw. Wader's tip, that was supposed to be sort of flexion or internal rotation of the humerus, which is going to be, as we know, a higher myotome. So that would be the higher roots. Really unlikely that we have the tumor all the way up there. Same thing with elbow flexion. It's going to be a higher root. And then also loss of sensation on the shoulder, which is the axillary nerve. Again, it's going to be a higher root. All right. Vasculature. Again, just to preface, vasculature is not too important. It's a good idea to know where sort of any important arteries run though, in terms of like complications for injuries and stuff like that. But they're not that important. A way that I like to understand the arteries is just to start from the aorta, which also knows near our heart, and then go through the route that arteries take. So starting from our aorta, we have our subclavian arteries. I won't really go over the branches of the aorta. But yeah, we have a right subclavian or left subclavian, which turns into our axillary artery, and that turns into our brachial artery, and that's going to bifurcate into the radial and the ulnar, which are going to have anastomotic connections in the deep and superficial palmar branches of our hand. One thing to note is a profundi brachii, which is going to branch off at the top of our arm from the brachial artery, and that's going to go deep into the arm. It's going to go near our humerus, and it's going to come back and anastomose around the elbow. Yeah, the left side doesn't have a brachiocephalic artery. You guys are going to do cardio stuff later on in the semester, but I guess just to give you guys a little hint on what's coming up. Our aorta, it comes up and around. Well, it goes back. But since our heart is on the left-hand side, it doesn't sort of need those branches to get all the way to the arm. It just has that left subclavian that takes us to the arm. Similar with the common carotid. But since it's on the left side, it's a longer journey to the right-hand side of the body. So that's how we have the brachiocephalic trunk there. Yeah. Yeah, so that's pretty much it. Those are the important things to know. I think for arteries, just the general area. The veins, not very important at all. I think having a general idea of where the veins are situated as well, and knowing that you can use the medial cubital vein for IV axis is also good. But yeah, just not a lot of high yield stuff with the veins. Okay, Rahul falls over and breaks his arm. Let's see, it's a pretty bad break. This is his x-ray. What are we concerned about? Yeah, E. The profundi brachii artery. As we know, that goes deep into the humerus and mid-shaft fracture, and it's a mid-shaft fracture, so that's specifically at risk. Anything else that you guys can think of that would be a concern here? That's not on the answers.
Radial nerve.
Yeah, perfect. The radial nerve as well, because we know they're both together. Great. And just to like continue with this thinking, can anyone mention some muscle actions that would be weakened by this?
Extension of fingers.
Yeah, that's good. Perfect. One really important thing with
opposition.
Yeah. So let me have a look. So someone's also said upper arm extension. So yeah, upper arm extension definitely as well, because the bone is broken, and as well as the radial nerve injury. One thing important as well to think about when we think about when nerves are damaged is where it's damaged. So for example, if a nerve is damaged at the elbow, then the upper arm is mostly going to be fine, because it's innervation beyond the elbow. That's the issue. But yeah, when it's this mid-shaft fracture, it will also be sort of the upper arm extension as well as some of the forearm extenders. Okay, let's have a look at some spaces. These aren't like, they're not the most important thing, but they are really good to know because they highlight where some of our arteries and some of our nerves travel through. And so it's a good idea to try and keep an eye on them. But I'm not too sure about the exact sort of exam or high illness of these. I don't really remember tons of questions on spaces. All right, we have our quadrangular space. Our borders are the teres minor, superiorly, the humerus, laterally, long head of the triceps. which is a medial one, and then finally the teres major. What are the contents? The axillary nerve and the posterior circumflex artery. The posterior circumflex artery just comes around and it supplies the head of the humerus. And if we can remember, is there any specific complication related to that artery? Does anyone have an idea of what I'm talking about? So basically, if we have a fracture that's at the top of our humerus, surgical neck around about there, or neck of humerus fracture, then the artery is at risk, potentially, as well as, that potentially is at risk there. And of course, our axillary nerve as well, right there. Okay, the triangular space, the lower triangular space, technically, also known as the triangular interval, which is right below that quadrangular space. That's why it shares the teres major as a border, but then it has the long head of triceps and lateral head of triceps as its borders. It contents radial nerve, the main one, which makes sense. It goes through that to come towards the posterior side and supply the triceps and supply those extensors, as well as the profundi brachii artery. All right. Sorry, cubital fossa. Accidentally skipped too much. A lot of borders here. Not the most important to know these borders, but have an idea. It's always like a good it's a good sort of space to orientate yourself. We can see here that you have to cut away the pronator teres to see the whole cubital fossa. Otherwise, it's covered, as well as otherwise it's covered, and so that can sort of indicate to you what layer we're at and how deep in the arm we are. What are the important contents? Well, if we go from the lateral side to the medial side, we have the radial nerve, which is on the lateral side, the radial artery branching off the brachial artery, as well as the ulnar artery, and then the median nerve of note. Okay. Supracondylar fractures, why are these important? Well, if we have a supracondylar fractures, we can damage the contents of our cubital fossa. Similarly with any elbow injuries, right? The stuff that goes through the elbow is going to be really important. We should also note that the ulnar nerve exists, and it's going to be going through our elbow as well. And so taking a note of those is a good idea. Finally, carpal tunnel,
Wait,
really
Bhuvan,
important
you
space.
went a bit fast. Could you please repeat what you just said
Fine.
just now? So sorry.
No, all okay. So what's important to know about that elbow region is that it's pretty dense, and there are a lot of connections to it, right? So our arteries and our nerves. So we'll have a look at it a bit later as well. But basically the idea here is that if we break our humerus at the distal end, then we can risk a lot of these structures, right? Because that fracture is going to be around about here, right? And we can see here we've got our median nerve, radial nerve, and our artery. And so when we've got a severe fracture like this, that's of specific concern because all the structures are going to be coming through here, as well as some minor structures on the back, right? If we remember like our funny bone, right? That's actually just a nerve, right? I think the ulnar nerve, right? And so if, for example, we have another fracture around our elbow, but it's going posteriorly into that nerve, then there's going to be damage there. And we'll look at that later, ulnar nerve entrapment of the elbow. Hopefully that helps to make it a bit clear what I'm saying.
Thanks, Bhuvan.
Okay, carpal tunnel, really important. Just know that the roof is a flexor retinaculum, and the carpal bones, specifically like the second layer of carpal bones or the distal ones, make up the floor and the surroundings of it. What are the main contents, guys? The median nerve, the biggest one, carpal tunnel syndrome, as well as the tendons for the superficialis and profundus, and also the flexor pollicis tendon. Important to note, ulnar nerve and artery, they go on for the Guyon's canal. So it is not going to be affected by any carpal tunnel syndrome. But yeah, that's the main part for carpal tunnel. It can be a bit confusing, but once you sort of label the diagram, you should have a really good idea of what's inside it, as well as the main importance, which is the median nerve. The anatomical snuff box, again, it's just between our two tendons for the pollicis, the extensor pollicis longus and extensor pollicis brevis, with the scaphoid and the trapezium as the base. Why is it important? Well, what does pain in our snuff box equal? What does that indicate to us? Yeah, yeah, perfect. So scaphoid fracture. Uh, it's going to indicate a scaphoid fracture, which is of particular concern as well, which we'll look at a bit later, as well as the radial artery, right, which goes through there and forms those branches, the palmar arches, sorry, not branches. Okay, now we're on to the pathologies. This is the most important stuff from upper limb, and understanding the pathologies can sort of work backwards because then you can understand the important muscles as well. So let's have a look at some of the key points in our pathologies. So we cover fractures, inflammations, as well as nerve palsies. So fractures, clavicle fractures. Do you guys know what are the most common clavicle fractures? Where they are actually? Middle third. Perfect. Middle third. Anyone remember like what point specifically as well?
Point of inflection.
Yeah, yeah, that's a good one. It is. It's a transition between convex and concave. That's going to be our most common fracture spot, which is in turn in the middle third, right? And so 80% of them are going to happen here at the middle third. After a fracture, we can see it's a pretty nasty one, but we can see that the lateral end is pulled inferiorly, and that's because we have our arm, right? It's going to be weighing down on that side of the clavicle. Whereas the medial end, it's going to go superiorly. That's because we have our sternoclavicular joint, right? And so it's going to keep that steady there and let it sort of spring upwards. What's at risk with the clavicle fracture? Anyone remember any specific risk with a clavicle fracture? Yeah, perfect. That's what I was looking for. Brachial divisions, brachial plexus divisions, a specific risk because divisions happen when the brachial plexus crosses the clavicle, as well as the subclavian artery is a minor risk because it is pretty well protected, and obviously we're going to have the bone sort of push into it for there to be a risk there. Okay. Humerus fracture. Humerus fracture, mostly just buzzwords here. If we remember where the fracture is and what damage it might do, that will help us a lot. So surgical neck, axillary nerve, makes sense because our axillary nerve is around that area, supplying the deltoid, shoulder patch region. Midshaft, we already know. Distal end, that's going to be our median nerve because, as we saw, the median nerve comes through our cubital fossa. And the medial epicondyle is going to be our ulnar nerve because that's where it goes behind our medial epicondyle. Oh, sorry, around that medial epicondyle. Which one of these is the most common? I believe the most common is the surgical neck, and that's where the most common surgeries happen. That's where the naming comes from. And a good sign is falling with your hands out in front of you. That might lead to a fracture in the humerus. Okay, shoulder dislocations. I know you guys had like a lot of tutorial. You had like a tutorial on this with like anterior, posterior, inferior. Why can't we have superior dislocations? Or why are they like super rare? Does anyone remember?
The coracohumeral.
Yeah, perfect. Right, where we've got this strong bone here. It's going to stop anything from going up. So it's more likely to go anterior or posterior, and sometimes inferior as well. But anterior is like beyond the majority of shoulder dislocations. And an anterior dislocation is going to risk the axillary nerve specifically. And that makes sense, right? Because our quadrangular space is around here, right? And so if we push it forward, it's going to, cause a little bit of a compression there. Well, not a little bit, a fair bit of a compression if it's very severe. All right. So Samak, he's playing a rough game of footy. He dislocates his shoulder anteriorly. His muscle movements are a little bit weakened, fair enough, but one of them is clearly the weakest. Which one of these shoulder and arm movements is going to be the weakest? What do you guys think? Okay, so we've got a little bit of a split. So C, E, I'm saying the main one that we're going to see is definitely C, and the reason is the deltoid, right? We know that anterior shoulder dislocations, they are going to risk they're going to risk the axillary nerve, which is a big supply for abduction with a deltoid. Other muscle movements may be weak, but the abduction is going to be the weakest because the deltoid is such a strong abductor for the shoulder region. And there are other things that do flexion and extension. There are other things that do flexion. So, for example, extension is radial nerve. Internal rotation, external rotation of the shoulder at least can happen in pecs. And then flexion can be taken care of with also some other muscles as well. Okay. Well, they're not supplied by the axillary. All right. Ulnar radius fractures. These aren't too important. I don't remember these tons. I don't remember covering them tons either. So I'm just going to more so leave this slide here for you guys to refer back to. But yeah, basically on Montegia, I don't know how to say it really. This fracture causes the radial head to dislocate, whereas I don't know how to say this one either. The Galeazzi fracture will cause the midshaft or distal radius fracture. But they're more likely to cause the radius fracture, I think, yeah. Okay, this one's more important, distal radius fracture. This one we form, so we have two types. When we fall on an extended wrist, we're going to get the Coles fracture, which is essentially the distal end of that radius breaking and pushing up, which I believe we can see here, right? The distal end of the radius is broken and it's causing us to push up. And so our hand is getting that shape that looks like a fork. On the other hand, if we're falling on a flexed wrist, it's going to be the opposite. Our bones are going to push they're going to push towards the palmar side of the hand. And so we're going to have a sort of dip in our wrist, just before our wrist, a dip inside it. The Coles fracture is more common because we're more common to fall with our extended wrists rather than our flexed wrists. Scaphoid fracture, really, really important. The main thing here is avascular neurosis because of the retrograde blood flow, which means it's working at grade gravity. So when we get a fracture right across the scaphoid, then it's not going to have any supply. There's not going to have any supply really for the scaphoid. Okay. Sorry, I was just replying in the chat. So it's not going to have any vascular supply for, for healing of the bone, and as well to supply the bone with what it needs. And so we're going to see the necrosis of that scaphoid. And also at risk as well is, the branches of the radial artery that supply the scaphoid and the rest of the hand. And as we mentioned before, anatomical snuff box pain is a big indicator. Okay, inflammations. These are really important, and they're all like the elbows. So first up, rotator cuff tendonitis. Our most common is a supraspinatus, big inflamed, and that's because it travels through that really tight space of the subacromial space, right? Which we can see here. And so overuse of rotator cuff, overuse of the rotator cuff can lead to this. The test that we do for this is painful arc, which is abduction from 60 to 120 degrees. And that's because earlier abduction is mostly handled by the other muscles. For example, the deltoids, I think, yeah. And as well, we have compression on the inflamed tendon when we're doing that part of abduction. Okay, bursitis. Do you guys remember what a bursa is?
Squishy pad of stuff that lubricates your movement.
Perfect. It's basically like a sac full of synovial fluid. Aim is to stop any grinding from bone-on-bone action, which is an interesting phrase. And basically, what happens in bursitis is we have inflammation because of a lot of action, a lot of overuse. The two main bursas to know is the subacromial bursa as well as the olecranon bursa, and they can both have bursitis. Of note is olecranon bursitis, which is student's elbow. And that's basically when either you have like a hard blow at the tip of your elbow where that bursa is, or prolonged pressure. And we call it student's elbow because that pressure is very similar to the one you see when you're like writing essays for exams, because your elbow tip is taking all that weight and all that effort. A lot more important elbows to know: the tennis elbow and the golfer's elbow. Sorry, there were some images on the side, but I'm not sure where they've gone. Basically, again, overuse equals inflammation here, with the tennis elbow being our extensors, therefore the lateral ones. I'm not really sure about this mnemonic. If you guys can memorize that, that's good enough. And then also the medial one is a golfer's elbow. I got confused reading this one a lot, but I would memorize the fact that Happy Gilmore, if you guys know the movie with Adam Sandler, like he flexed a lot, and so it's the medial epicondyle because that's where our flexors attach. And so this is all based on the action. So in tennis, they say use your extensors a lot. In golf, I guess use your flexors more, and the flexors attach at the medial epicondyle, the extensors attach at the lateral epicondyle, or most of them. Okay, that's that. Pathologies, the palsy. So this is our last bit of the lecture. Hopefully we can get it done in 10 minutes. A lot of palsies. Axillary nerve. What are we going to see? Essentially weakness of the innervation and issues with the sensory patch. Can anyone tell me where we're going to see sensation issues for the axillary nerve? Yeah, regimental badge, shoulder patch region, perfect. We're going to see sensation issues there. That's a big sign, as well as deltoid atrophy, because deltoid is the main axillary nerve muscle. Yep. Okay, musculocutaneous nerve palsies. The musculocutaneous nerve is a really, really well protected nerve. If we think about it supplying those arm muscles, it's really sort of pushed in there. And so to get to damage that, you really need like a big trauma, which is mostly actually a knife injury. Over 95% is like a knife injury. So if you hear the word knife, think musculocutaneous nerve. Symptoms, we're going to see atrophy of our flexors, and we're also going to see weakened flexion. But my question is, why will we still see some flexion? Why is all flexion not gone?
Because we got the brachioradialis.
Perfect. We've got the brachioradialis still to do its thing. And that's innervated by the radial nerve, as well as some more symptoms, weakened shoulder flexion, because the coracobrachialis there does a little bit of that, as well as sensation issues to the lateral part of the forearm. All right, radial nerve. These next three ones are a lot more important. They're a lot bigger, at least. So radial nerve, again, we know mid-shaft humerus fractures. They should tell us it's a radial nerve issue. What do we see? Well, the triceps function is going to be typically preserved because it's innervated superiorly to where this mid-shaft fracture would usually happen, or any issues around the elbow. And so what we will see, though, is wrist drop, which is due to unopposed flexion, and also some more weakness at the hand and thumb, and then diminished sensation. This diagram here, I would learn off by heart. You want to know what is innervated sensory, so what sensory innervation matches to what nerves. It is pretty simple in terms of on there being a lateral side, but then the radial and medial are a bit dodgy in my opinion. And those are the ones that I got confused with. So memorizing those is a good shout.
And wait, Bhavan,
Yeah.
sorry to bother you so many times.
No,
Is
it's
that
okay.
picture dermatomes or myotomes?
So these are dermatomes.
Okay.
This is sensory
And like,
innervation.
what did you mean by triceps is innervated superiorly?
So what I mean this is if we think about where the radial nerve damage will happen, it's if it's a mid-shaft fracture, it's not going to necessarily damage the innervation of the radial nerve towards the triceps because it's going to receive its innervation superiorly to that lesion, essentially. Does that, does
Oh,
that does that make sense?
so if it's like further down, it won't damage the triceps.
Yeah,
Further down from where the triceps is.
perfect. And like if we think about like electrical wires, right? Um, like it's still going to transmit until the point of the cut or until the point of the damage. That's when it's going to get a little bit dodgy. But anything before that, like the electricity is still flowing through, or nerve signals, they're still flowing. And so that's why we have to remember that superior to our issues or proximal to our issues, we're going to be fine. Distal is when we have to think about what's going to be damaged. And that's especially important when looking at the ulnar nerve. But median nerve, again, big one, carpal tunnel syndrome. This leads to thenar wasting. Why aren't we losing this palmar sensation though? Well, I mentioned before really small. Yeah, perfect. The cutaneous branch of the median nerve comes off earlier, and that's going to be responsible for that sensation. So the main sign, thenar wasting, as well, if you remember in clin skills, you guys probably went through a bunch of other carpal tunnel syndrome signs. Okay. Also, to note, hand of benediction. This is going to occur when we have trauma at the elbow. This is going to be the loss of the first and second digit flexion, and the third and fourth digit will be spared because, as we know, the FDP has split innervation with the ulnar. Now, in both of the carpal tunnel and the hand of benediction, we're going to see sensation loss over the lateral 3.5 fingers and nail beds. Well, sorry, not in both, just in hand of benediction, my bad. Yeah, sensation loss, my bad. I'll change the notes there. On the nerve, this is a big one. This is where we can sort of really see the idea of the lesion location mattering, because where it happens is going to change what we see. So ulnar nerve palsy will always present with this ulnar claw, usually, and that's because the flexion at the interphalangeal joints will be a bit dodgy, as well as hyperextension. So that's what it's going to cause. Sorry. Now, what you'll be able to do here is you'll be able to make a fist, but you won't be able to make a flat palm. Now, if we have trauma at the elbow, we're going to see forearm damage included. So that's going to be lateral half of the FDP, as well as radial deviation of weak flexure. So that's when we should see the ulnar claw. Whereas the Guyon canal compression, we won't see any radial deviation because the forearm damage is not happening. So we're not going to see any deviation on radius, and we'll see weak wrist flexion. So we have a really good question about how do we tell the difference? What's the difference between the hand of benediction and the ulnar claw? Okay, so the big test is that in ulnar claw, you can make a fist, but you can't make a flat palm. And that's because the lateral two fingers are flexed, right? With a hand of benediction, we can't make a fist, and we can't flex the medial two fingers. So my question is, what's the difference between the issue, right? In the ulnar claw, we're getting an issue in which digits, I guess. Which digits are problematic for us with the ulnar claw? If we think back to half loaf half, for example, half of the lumbricals are going to be inside the, half of the lumbricals are going to be with the median, right? The lateral half. And so our lateral two digits, these ones, they're not going to be problematic. They're going to be problematic with our median nerve, right? So the issue there is that we can't actually make a fist. We can't flex these two fingers, right? And so the hand of benediction, we see it when we're trying to flex our fingers, right? That's when we get that issue. It's an issue with the lumbricals here. With the ulnar claw, it's the reverse, right? These aren't problematic. It's our pinky and our ring finger. Those are the issues, essentially. And so that's why they're flexed. It's basically because of a lack of the extension, I think. Yeah, let me double check. No, sorry, it's flexion. Yeah, it's flexion and hyperextension of those joints. So hyperextension and then flexion here. And so the issue itself is different. Even though it's sort of similar, we're not actually looking at the same cause. Does that make sense? That really helped me understand it, but I'm not sure if it helped you guys. Okay. Yeah, okay, perfect. All right, final one, I think final two maybe. Long thoracic nerve, C5, C6 to 7, wings to heaven. You can see it usually. Sometimes you can't see it. So basically, we can't make a flat palm. So when we flex our hand, it's the lateral two fingers in the ulnar claw that are flexing. And our medial two fingers are staying. Sorry. It must be, that must be a mistake in the notes. Yeah, right. Sorry. It should be our lateral two fingers are extending, but our medial two aren't. Sorry. My bad. Let me change that. Good one. I didn't even pick up on that. So yeah, long thoracic nerve, C5, C6, 7. And then also, no, this is not long thoracic nerve, my bad, but it's just Erb's palsy and Kumke's palsy, which are just issues with the actual roots in our brachial plexus. The signs are these ones here. We see Wader's tip sign, as well as the Klumpke's palsy sign. So when does it happen? Traumatic birth for Erb's palsy, usually like when they're coming through in birth and their neck is sort of shifted like that, when the neck comes out last or the head comes out last. Klumpke's palsy, stuff like hanging from trees, limbs basically being pulled superiorly is going to lead to that damage. All right, so that was it for upper limb. There weren't a lot of questions, but Raman, as I said, is going to have his Kahoot later on, so stay tuned for that. Anatomy can be really tough. It can be really busy, and there's a lot more anatomy to go for this semester. But I'm sure you guys have got this. It's hard as well in lockdown. But yeah, definitely like keep sending feedback to the faculty, hopefully, to let them know what you guys need, and feedback through to MUMUS about what you guys need as well in the second half of the semester. And hopefully it gets a bit brighter. One thing I can say as well is that spending the whole year in lockdown, spending this semester in lockdown makes so the after exam party and after exam fun a lot more fun. So at least we can all look forward to that. All right, that's it for me. Hopefully Raman is here now and he can take over for the lower limb.
Move on. Just something, the lower limb or whatever, the myo and NeuroPhys presentation is locked on the drive.
Yeah, I'll get him to fix that before.
Yes.
Hi guys, Raman.
Hi. All right, so let me share my screen. So basically, it's a slightly different revision lecture. Well, lecture. I say lecture. But basically, you guys have already done. You've just finished level limb, I presume. So I figure there wouldn't be really much point going over, the content again, because that's, let's be honest, it's fairly sort of basic content. It's not like physiology where you have to understand it. It's have a look at this and memorize it. So I thought what we would do, what you could probably benefit the most from, is going through some questions, some exam questions, and seeing, I guess ways that you can approach studying for the exam, ways that you might approach how you learn or revise a lower limb for the end of the year. I guess just some extra little high yield things that you can keep in mind. So basically just an addition to the work that you've been doing so far. Okay. All right. As for the presentation link, it's literally just questions from the exam. So I'll send it to you afterwards, but you really don't need it because all the information is either in the exams that you'll get anyway. I'll share it anyway, but yeah, I don't send like PowerPoint. I'll send it to you afterwards, but yeah, so I wouldn't worry about writing notes or anything. Like it's just sit here and sort of, I guess, do the questions. Anyway, we'll get started and hopefully you'll see what it's about. But yeah, not really intensive or anything, so I won't worry too much about it. All right, so we won't do this like a Kahoot. We'll basically, I'll give you a second just to familiarize yourself with the question. I maybe have a little bit of a go, but then we'll just have a chat about it. So yes, 90-year-old Mrs. Chong fell out of bed and experienced severe hip pain in her left hip. Hip pain in her left hip. Of the following types of fracture involved in the upper end of the femur, the most likely to significantly interrupt the arterial supply to the femoral head is denoted by the blue. Actually, you should pick a number. Where would a fracture interrupt the arterial supply of the head? And you might go, okay, sure. Let me just, pull out my notes and see, what artery comes out here. And yeah, okay, again. So again, you can approach the exam by memorizing all the arteries, memorizing the location of all the arteries. That, that's fine. That's good. And if that's what works for you, that's fine. But for someone like me who's a little bit lazy and can't be bothered memorizing, okay, a lot of what you might consider doing could be based in like logical deduction instead. So as opposed to memorizing, you sort of have a couple of things that you know, and you can sort of deduce things from there. It might not be as accurate as if you had memorized it in the first place, but it could be another approach if you find that memorizing is just not something that you want to be doing. So for this question here, all right, we'll think about, okay, what's femoral head, right? We're going to think femoral artery, right? But just off the vague location of the femoral artery, we know it doesn't go wrapping itself around the femur, it just goes straight down basically. So it's going to have some branches. Okay, now obviously the question isn't asking us for the branches, but we'll talk about that anyway, because obviously you need to have some knowledge of it to be able to answer the question. And so basically what you need to do is just track the artery. So I think, well, yeah, I mean, I'm assuming you've learned about the arteries for the lower limb. Okay, and what you can do is you can just, again, memorize everything or have a vague idea of where the arteries go and the high yield points, and that should be enough to carry you through the exam. So high yield point for the hip joint and the arterial supply of the hip joint is the circumflex arteries around the femoral head. So if I give a rough drawing of it, this is not going to be perfect, but you have your medial and lateral circumflex arteries, which will, let's assume this is the femoral artery here, got coming around this side and behind to the medial and lateral, and they'll they'll supply the neck, and then I think the next question is actually about this, but they'll go then into the head. So naturally, if you have a fracture here, blood supply to the femoral head is going to be cut off. So high yield point, so yeah, the answer would then be the femoral neck fracture there at 2. Okay, so again, high yield point, the circumflex arteries, and just a small note, nothing too important, the medial circumflex artery supplies the majority, but that'll come up. Okay, second question on this. Why would a fracture at the area 1 cause avascular necrosis of the part indicated? Okay, again, similar sort of thing based off your understanding of the blood supply. Okay, and so now that you know this high yield point about the circumflex arteries, and through the diagram that, again, this is not an exact positioning of the arteries, but it's a general concept that the arteries come off the femoral artery through the neck and end up at the head. Okay, so you're not memorizing the exact location, bony landmarks, whatever. I mean, you can if you want to. Probably very important if you become a surgeon, but for the purposes of this exam and for your understanding at this stage, I really don't think it's that important. So yeah, give you a quick second just to have a think. All right, so the answer here is going to be C, the retinacular vessels. So again, if you weren't aware, the retinacular vessels are just an extension of they're just branches off the circumflex artery. So the circumflex arteries come around here, and then your retinaculars go into the head. Okay, again, that kind of stuff. But you could also do this by a process of elimination anyway. But we won't dwell too much on that for now. All right. That's again, one high yield point about the arteries. Again, just highlighting that you don't have to memorize everything. Memorize the key points, memorize the key arteries, and then you can logically go around from there. And I guess the general positioning of the arteries, where do the veins go? Where do the arteries go? Do they go behind the knee, in front of the knee, to the side of the knee? Because, if you injure a certain place, a lot of the questions on the exam are going to be clinically based. Well, not a lot, but most of the anatomy questions are going to be clinically based. They're not going to ask you, okay, what artery supplies the thigh, right? Maybe one question like that. Everything else will be some guy does this and this happens. All right. What is in danger? What's responsible? What bones are going to be damaged? What vessels are going to be damaged? So in order to be able to know that, you can't just memorize everything word for word. You have to have some holistic understanding of where everything is in relation to each other, in relation to key structures, et cetera, et cetera. So yeah, but we'll go through some of that stuff. Blah, blah, blah. Track the arteries as usual. Which is medial and which is lateral. Sorry, I should have mentioned that earlier. Again, you can look up a diagram, but logically, I haven't memorized. It's been a long time since I've done lower limb, but in my head, medial and lateral. Let me think about it. I think this is the. Oops. I think this is the left. All right. I think this is the left hip. I think that's what they said. So if I get my diagram right, medial and lateral. Okay, one artery is going to be coming out from the femoral artery around the top. One's going to be coming out around the bottom. So logically, if I was thinking, okay, which one's the medial and which one's the lateral, I would say the medial would be the one coming out in the front and the lateral coming out in the back. But depends on, yeah, that's what I would say. Yes. Basically, whichever artery is more medial, which I think would be the one coming out in the middle. You'll have to double check that, but I'm pretty sure that's what it is. So again, you know, I haven't memorized everything, so I'm not going to get it 100% accurate, but I'll have a general idea. My general idea tells me that the medial artery, the medial circumflex artery will be coming out in front. Maybe it goes higher, I don't know, but roughly that's where it is. Fact checking on that one. All right, next question. A 35-year-old man developed legend gait while recovering from a sports injury. Whenever he lifted his right foot off the ground, his pelvis would drop on the right side. A nerve injury was thought to be the cause. The root value of the affected nerve B. Okay. Now, there's a couple of ways of going about this. I'll let you just grapple with the question for a second, but there are a couple of methods. We'll talk about that in a second. All right, so, okay, so, you know, nerves are very, you know, nerve roots, innervation, functions, that's basically, I guess, I would say, the stuff that is tested a lot on the exam. So it is important that, again, you wrap your head around it holistically. So if I go to the next, yeah, okay, so first method that I could say you might want to start thinking about these questions in is, I mean, obviously you could just memorize this. Right, memorize the answer and I guess memorize all the different scenarios, but that would just not be the most time efficient thing you could do. So what else might you do? Right, first, one method you could talk about, or you could go about, is sort of thinking about it from the muscles perspective. So this guy's lifting his right foot off the ground and his pelvis would drop. Okay, so obviously something's not working, and that something will be your muscles. Right, so what muscles are going to be not working or weakened? Right, on that's going to be resulting in this sign or this presentation. That's the first thing. So if you think about it, okay, in my head, I'm going, all right, I'm probably looking at hip muscles. Okay, what muscles are thinking about this movement? Okay, and again, I'm thinking about this logically. You could memorize all the muscles and the functions, and that's fantastic. But if somebody struggles to memorize, or you just can't bother it, you could sort of take a bit more of a deductive approach, which again, is going to reduce your accuracy, but it's kind of a cost that you have to decide if you're willing to pay or not. So I'm thinking probably going to be your gluteal muscles, all right? So the abductors, I believe. That's what I would say is causing the pelvic drop on the right side, because if you think about it, if you're lifting your foot upwards, in order to compensate for the natural movement to sort of tilt that way, your body would be pulling your hip, I guess, outwards. So that's what I would say. And again, by a process of elimination, I don't think it would be a flexus or your extensors, because that's, you know, moving hip up or down. So I have a feeling it would be abductors. All right, so let's go with abductors for the time being. It could be adductors, for example, but I think just logically, I feel like it will be abductors. All right, so now that I've settled on that, which muscles abduct the hip? I think I said that before, the gluteal muscles. There might be a couple of others here and there, but generally, I think the gluteal muscles do abduction. Again, there are so many muscles, you can memorize the functions of all of them, and that's fantastic. I would recommend doing that. But from a perspective of somebody, you know, who isn't learning lower limb at the moment, I'm kind of rely on stuff that I've learned previously. It's almost a better way to just think about them as like muscle groups of function. So abductors, flexors, okay, because if something is wrong, you know, you can't flex your hip, that group of muscles is going to be what you're looking at. So yeah, gluteal muscles. What nerve innervates these muscles? Well, gluteal muscles, I'm thinking probably gluteal nerve. And I think, just from memory, it's the superior gluteal nerve that innervates the majority, not all, but the majority of the gluteal muscles that abduct the hip. Okay, and so the root value of this affected nerve, the superior gluteal nerve, comes from L4, L5, and S1, I believe. All right. So that's kind of how my process of deduction would work. Okay, so you're kind of working backwards in a sense, okay, but you're just taking it takes longer, evidently, right? Because you're going, okay, this is correct, and now how do we get from here to here? How do we get from here to here? And you're taking a few steps. So yes, it is longer, but the burden on your, I guess, memory is less. So again, it's not, I'm not saying you have to do this. I'm not saying this is the best way. I'm not saying this is going to get you 100% of the exam, but it's just another way for you to think about how you might approach learning, revising, and preparing for your exam. So the next method is, again, just another angle. All right. So, and I would recommend actually having multiple angles because it can be a good way to just check your answer, especially if you're doing something where you're not actually memorizing the answer, so you're not 100% sure. Okay, so if we go by the myotome route, okay, if you guys don't remember what a myotome is, like a dermatome is like generalized muscle movements based on nerve roots, okay? So similarly, instead of going to the muscles, we'll go straight to the movements. What movement isn't functioning here? And that, again, like we said, is abduction mostly. I'm sure there's some other thing there, but mostly, generally, abduction. So what myotome is responsible for hip abduction, okay? And obviously, this, again, is something you could memorize. We'll go through this in a second, but myotomes and dermatomes are probably worth memorizing just to have off the top of your head. But again, there are ways that you can logically deduce them, and we'll go through that in the next couple of slides. Again, like we already know, the answer is L4, L5, and S1. But if you know that hip abduction is L4, L5, S1, you can connect that to this question. Now, the question doesn't ask you for the myotome, but using your knowledge, taking a holistic approach, connecting everything, you're able to sort of bring that knowledge together. And the fantastic thing about these exams is they're multiple choice. So you can use that knowledge to eliminate answers and narrow down your options. So yeah. Right, but myotomes, I personally can't say I knew my myotomes going into the exam. I still don't know all of them. But there is, it's good to memorize them, but there are some logical ways of thinking about them. Okay, so here are the myotomes for your lower limb. Again, you guys should have this from your clean skills and whatnot. Again, you can memorize it, that's fine. But just to show you the power of, I guess, logical deduction, let's have a look at the 5 big nerves of the lower limb. So we'll start off with the femoral nerve. Okay, so the femoral nerve roots are L2, L3, and L4. Okay, and what does the femoral nerve basically innervate broadly? They innervate a bunch of different muscles, 6 muscles here. Okay, but what are the functions of those muscles? So in a sense, what is the function of the nerve? The motor function of the nerve. That is hip flexion and knee extension. Okay, so if you have a look at the myotomes here, hip flexion is L2 and L3, and knee extension is L3 and L4. Putting them both together, you get L2, L3, and L4. So you can see how my knowledge of the femoral nerve and its roots and its functions, also what it innervates basically, can help me gather what myotome or what the nerve roots might be. Now you might be thinking, hang on, why isn't hip flexion L2, L3, L4? Well, potentially L4 only does the knee extensors. Well, L2 and L3 only does the hip flexors. And that's something you'll have to memorize. So again, like I said, this is not just having, I guess the power of deduction is not a precise thing. If all you knew was the femoral nerve, its roots and its functions, you might assume that hip flexion is L2, L3, L4, and knee extension is L2, L3, L4. So it's not precise, but it gives you a general idea. Okay, and that's, I think, is a good asset to have for a multiple choice exam. So yeah, now if we talk about the obturator nerve, okay, roots L2, L3, L4, and it innervates the hip adductors. Maybe not all of them, but most of them anyway. Okay, so hip adduction is L2, L3, L4. Notice how the way that I've structured this, I've structured the muscles by function and category, basically. It becomes easy to think about it. So instead of thinking, oh, the obturator nerve innervates this muscle, that muscle, this muscle, so I can't remember it. You can think about, okay, I know the obturator nerve innervates basically the inner thigh, which are your adductors. So I know the general location. So if someone was to cut my inner thigh, I'd be thinking, oh, hang on, obturator nerve is at risk. Okay. Again, it's not a memorized thing, but I have a general idea of where it goes. So generally, I can I cannot assume, but I can deduce. Might not be exactly correct, but I have a general idea. Okay, so sciatic nerve, hamstring muscles. What do the hamstring muscles do? Well, knee extension and hip extension and knee flexion. So as you can see, a similar sort of thing. And the nerve roots for the sciatic nerve are L4, L5 to S4. And you'll notice
Raman, sorry to interrupt. I thought they were to S3 because that's what our notes said, I think.
Okay, well then go with that. All right, maybe my notes is wrong. I wouldn't, not too much of a big deal, but that makes sense anyway, because if you look at hip extension, knee flexion, S3 and S4 are not there. But the reason that I was going to say anyway, the reason that they may not be there is because, as you probably know, the sciatic nerve breaks off into tibial and common fibula. So potentially L4 and S3 probably contribute to those those nerves and those myotomes and what they do. So that's where it becomes a little bit more complicated, similar to the brachial plexus, right? You might have a bunch of different branches connecting together, but it doesn't always mean that those branches go into that nerve. They might just be passing through, for example. So it doesn't always give you the exact precise, answer, but it's just a good way to generally have an idea of what's going on. So I still would recommend having, so you're memorizing the myotomes, and there are probably some acronyms and whatnot you can remember, but having a general understanding puts everything into context. And then it becomes a lot easier for you to then think of everything holistically, as opposed to, here's my myotomes and here are my nerves. As two separate things, basically. But once you understand that everything's connected, it can become easier to piece things together when you are answering questions. So yeah, but obviously, like for example, knee flexion is only L5 and S1, not a whole lot. So that is where you might have to start memorizing. Right, common fibular nerve does those things. Again, fairly straightforward stuff, similar to the what have we been talking about so far? Reversion and plantar flexion, tibial nerve. All right. And hip abduction is the only one not covered by those 5 major nerves. Ironically, the question that we had, so the hip abduction is covered by superior gluteal nerve. Right, so yeah, those 5 big nerves plus this extra one cover all your myotomes. Okay, and again, you can use that to remember what the function of each nerve is. Okay, broadly speaking. So everything's interconnected, and that can really help you. All right. Next question. A 44-year-old woman sustained a fracture of the ischial tuberosity and injury of muscles attached to it. Which of the following movements will be affected in the hip joint? I'll give you a second. All right. So again, a lot of the PSPs when I was learning, they didn't really stress the attachments and origins too much. They mentioned that, but it wasn't something that I thought was particularly important. But there ended up being questions that might have alluded to or involved attachments and origins. So it's not a bad thing to know. But again, for me personally, someone who was very lazy and couldn't be bothered learning all of that. Again, just using logical deduction can help. It won't give you the precise thing, but it'll give you the general idea. So for example, ischial tuberosity, where is that? That's, if I draw a hip for you. Oh my God, this is going to be bad. Let's assume this is your hip. Okay, it's terrible, forgive me. This is your little hole there. It's your pelvic symphysis and whatnot. That's your other hip. Okay, your ischial tuberosity is basically this part here. Correct me if I'm wrong, but that's broadly where it is, I believe. Okay, so I'm thinking about my leg. All right, what muscles are going to be connecting there? All right, they're probably going to be the adductors, right? Because they're connecting from the medial side of the leg to the medial portion of that. Actually the inferior portion of the hip. Now they could be on the, the front of the anterior portion of the femur and then coming around. It could be from the back coming around, but generally it's that side. Again, I'm not saying all the muscles on the left side, so the medial side have to connect to the ischial tuberosity. It's just generally, I know that muscles on this side are not going to be connecting there. Okay. So generally I'm looking for what functions, okay? probably going to be, well, I would say adduction, and then that would be D. But at the same time, I also remember, just because of my knowledge of the leg, that muscles in the posterior compartment of the thigh connect to the ischial tuberosity as well. All right, so again, that's why I caution it's not a precise method. Because if you just purely went based off logic here, you'd probably go with potentially D if you assume that the muscles come out of the front and the side. But actually, it's more so the back and the side my God, I can't speak. That is where I forgot what I was saying. But basically, that's where the muscles actually are. So you have to have some understanding, and that's where this kind of whole process of deduction can let you down a little bit. All right. There's got to be a mix of both. But I'm just trying to show you something that you might not have thought of when you were sort of learning about this. So if we take that, for example, I think from memory, it's like the semitendinosus, I think definitely attaches to the ischial tuberosity. Just by remembering the positioning of it, I think it's more so here, I believe. But anyway, those hamstring muscles are going to be responsible for hip extension. And so we've got extension here. All right. Again, if I was logically deducing this, I might think about adduction as well, but flexion does seem unlikely, given that most of the flexion is conducted by the anterior muscles, which in my opinion wouldn't really attach here. That's where I kind of get a bit iffy. So if I was doing this in an exam situation, I'd go with C, even though I'm not 100% sure that I know exactly which muscles attach where. So it's lucky that they've put this as well, otherwise it might have gone with D. But yeah, I believe the answer is C in this case, extension and lateral rotation, which I guess does kind of fit with the muscles being in the posterior compartment of the thigh. But again, I'm sure if you looked it up, you could find out exactly which muscles are involved here. And note, if you want to learn that, that's fine. But again, just showing you another way of thinking that may or may not be beneficial to you. Yes, what's that? All right. I think I already drew that diagram, so don't worry about it. All right. Next question. I think it's only about 10 or 12 minutes, so too long. Physical examination of a patient with an ankle injury was suggested of a complete left Achilles tendon tear. This diagnosis was confirmed by the findings revealed when the doctor squeezed both the patient's calves, left and right. Which of the following examination findings of the above test would support the diagnosis of a complete left Achilles tendon tear? It's a very long question. You probably don't need all of that information, but yeah, this is a little simpler compared to some of the stuff you've gone through previously. So we won't spend too much time on it. But basically, it just comes back to what is the function of the muscle that we're testing here. The muscle that we're testing, hopefully, you'd be able to figure out that it's the gastrocnemius, which is your big calf muscles, basically, the biggest part of your calf. And so logically, again, I don't memorize the functions of most of the muscles, all right? But again, if I was thinking about the calf, all right, where does that go? This is your leg, side on view. This is your calf, goes underneath your foot. All right, if you contract it, what's happening? The foot's going to come down. So the function, one of the functions anyway, of the gastrocnemius would be plantar flexion. Again, remember the way I remember plantar flexion is you plant your foot, the bottom of your foot is going to be plantar flexion, dorsiflexion, dorsal is the top, dorsal fin. So that'll be moving your foot up. Okay, so their left plantar flexion will be gone. All right, but just as a side note here, in explaining the question, the reason they're talking about right ankle flexion is maybe the person doesn't have, maybe in both legs they have some issue, and actually they weren't able to plantar flex anyway. In which case, you wouldn't be able to diagnose them with a left Achilles tendon tear for sure because you don't know. So to assess, I guess, the norm, quote unquote normal, we have to look at what the function of the right calf would be. And so if they do plantar flex in the right ankle, that means, okay, we've got an issue with the left. But if they don't, maybe they have some, I don't know, nerve problem, or I don't know, I'm not familiar with this, maybe some other problem that prevents them both from, I mean, naturally they weren't able to plantar flex for whatever reason, I don't know. But that's the reason for this. So yeah, all right, so you'd go with right ankle plantar flexion only. Because again, yeah, left ankle is not going to plantar flex because you've got a broken Achilles tendon. And dorsiflexion definitely not, because remember, gastrocnemius it doesn't deal with dorsiflexion. Any muscles that have dorsiflexion will have to come from the front or the side of the leg in order to end up at the top of the foot. All right. So yeah. Yes, we did that. All right, so a motorcyclist injured his right knee in an accident. The ER doctor noted a deep laceration of the lateral aspect of the knee. Patient was noted to have a foot drop. Which of the following nerves injured? So again, where do these nerves go? Following and remembering the paths of the nerve throughout the leg is going to be important for these pathology style questions. Again, you can't memorize this. I mean, you could memorize this, but if you have a good understanding of the pathway of the nerves and the function of the nerve, then you'll be able to piece this a lot easier, piece this together a lot easier. I'll give it a second. Basically, okay, first thing, understanding the location, and then obviously understanding the function. All right, so this rough drawing here, look at the peroneal nerve, obviously, the fibular nerve, it comes out laterally and then comes out anterior laterally, whatever you want to call it. Most anterior being the deep fibular nerve. Okay, so foot drop, right, it's going to be an issue with dorsiflexion. Right, and look what nerve pops out on top of the foot. It's going to be the deep fibular nerve, because that's the one that's coming out on the front. I don't need to memorize what the function of this is. If I know the location, all right, I know it's going to innervate the muscles of the top of the foot, which, do dorsiflexion. All right, so again, just a bit of logical deduction. I'm sure maybe, this muscle here also does maybe inversion or something, eversion or something like that. Okay, so you're not memorizing it. You're not going to be able to get every single piece of information from this kind of broad thinking. I really want to emphasize that. It's just understanding, just gives you a general understanding, a holistic idea of what's going on. So again, I'm going to assume that the muscles in this anterior compartment of the, I forgot this calf, lower leg, are going to be innervated by the deep fibular nerve. All right. I don't have to memorize all of them. Just generally, if I know what muscles are there, and I know the nerve goes through it, I'll infer that most muscles are going to be innervated by that nerve. So yeah, the answer would be B in this case. Oh wait, hang on. Could be A as well. Actually, no, sorry, not B. My bad. Because he injured his right knee, so it'll be the common part there. All right. So again, pays to pay attention to the question. All right. During a badminton game, a player felt a sharp pain around his ankle associated with a snapping sound. He had difficulty ambulating on the limb. Immediately taken to ER. It was noted that he was not able to plantar flex against resistance. Radiographs did not reveal any bony injuries. Which tendon was most likely injured? All right. Now, okay, this one's a little more of a buzzword type question. But again, you could obviously think about the plantar flexion, sharp pain around the ankle, and you piece that together. All right. But this is a more of a buzzword style question, which is snapping sound in your ankle is an Achilles tendon tear. You might have heard about this in skills potentially, but often people will describe, or patients will describe, an Achilles tendon tear or damage as like a gunshot wound kind of feeling. So that's kind of your buzzword for an Achilles tendon. It's very kind of sharp, snapping, gunshot style kind of pain and sound, I guess, when the tendon snaps. But obviously your plantar flexion and sharp pain on the ankle are also clues that it's going to be the Achilles tendon. So yeah, that's just A. All right, cross sections. I mean, look, if you ask me to name all the muscles here, I wouldn't have a clue. It's quite difficult. But again, you could use a process of deduction to figure this out. But yeah, for this question, you don't need to. In the cross section of the middle of the thigh, in the image with the following segments, best describe the triangular area inside the black circle. Okay. So again, try and visualize what the leg is. What are we looking at? Okay, this is your medial side. This is your lateral side. You can tell by the positioning of the femur. All right, positioning of what I presume these to be vessels because of the, the hollow tubes there. But also you can see the shape of the leg as well. Gives you an indication of which side is medial and which side is lateral. Okay, well, they should really say that in the question. Okay, so there's a next slide. But yeah, okay, so there's two ways you can go about this. First of all, what is the area? So what is this area? And then once you know what it is, you can use your memorized knowledge to determine what the contents of this are. For example, if I said this was part of the femoral sheath, okay, I know what's in the femoral sheath. And then so you can connect those two dots and say, okay, well, the contents must be blah, 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 blah. Or if you have no idea, you can take a little more of a longer route, but a more deductive process, which would be, all right, where is this? So this is in the medial thigh. So just visualizing where everything is, medial thigh. All right, so what major vessels and nerves and stuff go down there? Okay, well, got the femoral nerve, the femoral artery, which is accompanied by the femoral vein. They're going to go down the medial thigh. All right, now what innervates the medial muscles? They're adductors. So I remember from before we talked about the obturator nerve, dealing with that. Femoral nerve potentially, because you've got femoral artery, femoral vein, so it could be femoral nerve as well. So I'm thinking those four, and I could be wrong, all right? But that's, again, this is what I'm getting from logical deduction, again, which is not 100% accurate. So I'm not actually 100% sure where the femoral nerve goes. I think it actually goes around the front of the thigh because it'll innervate the flexus of the hip. So potentially it's not going to be a part of this little pocket of neurovasculature. So I'm leaning more towards femoral nerve, vein, and the obturator nerve. I figure the femoral nerve will probably be more around here, especially because it's the middle of the thigh. All the nerves would have likely sort of separated out of the hip by now. So that's what I'm leaning towards. Again, I don't really know what this, I wouldn't be able to tell you what this was just by looking at it. And then obviously once you've determined where that is, you can say, okay, it's most likely to include femoral artery nerve, obturator nerve, blah, blah, whatever we just said. And then you can sort of answer the question. I think this actually might be the adductor canal, but again, like I only knew that because I researched it. I wouldn't know that off the top of my head. So yeah, the answer would be C here, because we know, well, we infer that the femoral artery is going to be a part of this little neurovasculature bundle. So that fits with C. Okay. Now, obviously, if you want to eliminate D and whatnot, like I don't know the exact positionings of those muscles and the borders and whatnot, borders of the adductor canal and all that stuff. So you might have a little bit of a harder time eliminating it, but it can help you get sort of X distance far. So yeah. All right. A stress fracture, the anterior margin of the tibia, has resulted from poor foot mechanics. The associated swelling has impacted a nerve in the compartment immediately lateral. The sharp anterior margin of the tibia. So big words, whatever, just try and visualize it. Okay, anterior margin of the tibia, lateral. Okay, so go looking for the outside of basically the outside of the leg. Weakness of what movement will most likely be evident? Now, again, we kind of covered this already with that previous question. So lateral to the tibia, lateral to the sort of front of the tibia is going to be your peroneal nerve, fibular nerve, whatever you call it. So again, my general understanding is the fibular nerve innervates the anterior and lateral side of the leg just by the positioning of it. Okay, and the tibial nerve will innervate the posterior because I know it goes behind. All right, and then it goes under the foot to the tarsal tunnel, so it must innervate those plantar flexing muscles underneath the foot. Whereas the deep tibial nerve will innervate the top muscles, so it'll be the dorsiflexion muscles. So anyway, coming up to this question, right? You could memorize the function of the nerve, you could memorize all the muscles it innervates, but just by looking at where it goes, we're probably going to be dealing with an absence of or weakness in, let's see, foot eversion, potentially, knee flexion, nope. Toe extension, probably not. Actually, toe extension. Got which way toe extension goes? It goes down, I believe. Anyway, it's not going to be ankle adduction. Ankle flexion, nope. So I'm thinking foot eversion or potentially toe extension. Okay, so this is where thinking broadly can have its deficits. So yeah, I'm not 100% sure. Obviously, I have the answers. And I think the answer is E. But if I was doing this, I would have some trouble distinguishing between C and E. I suppose foot eversion, maybe they're under the foot potentially. I haven't memorized the foot muscles. So maybe in gray areas like these, it might be worth memorizing and distinguishing. But for more general things, maybe you don't have to memorize it as much. Up to you. But yeah, you can see the deficits of this method here in this question. So yeah, I think the answer is E. But yeah. All right. Anyways, I think this is one of the last few questions. Ankle flexion. Yeah, I think ankle flexion is referring to dorsiflexion. Correct me if I'm wrong, somebody. But yes, just by general movements, if you flex your ankle, I think that would be dorsiflexion. Yes, I believe. Which one of the structures? Okay, this one's a bit simple actually. I thought it would be a little bit difficult, but actually it's not that bad. So this one's just basically being able to figure out what's what. I think I was just running out of questions at this point. But yeah, general understanding is what's where. So just going through it. Number one, probably going to be your, well, this looks medial, so it's going to be your vastus medialis, if I had to guess. Two, probably vastus lateralis, if I had to guess. Three, okay, because you've got your muscle here, muscle here, muscle here, and they all conjoin to make a single tendon called the quadriceps tendon, which goes over the patella and then comes down. And I think this part here is called the patella tendon or patella ligament, but it's all one thing basically. So yeah, no, I don't know what 4 is, but I guess that's enough information for you to be able to deduce. All right, again, A, one is supplied by ventral divisions of L2, L3, L4 nerves. So one is a vastus medialis, most likely. Was that supplied by femoral nerve? That's femoral nerve roots. I think it was L2, L3, L4. Is it? Can't remember now. Anyway, whatever it was, I think it is L2, L3, L4. Oh, actually, I think it was an issue. I think so. Someone correct me if I'm wrong, but I believe so. Anyway, let's continue eliminating. 3 is enough for me. Flexion. No, it's an extension. 4 marks the site of insertion of one of the muscles. The hamstrings, nope, because we know hamstrings are posterior. So posterior, I think there's one that attaches laterally, but mostly posterior. 2 originates from the hip bone. Again, I'm pretty sure most of the flexors, just generally speaking, attach at the top of the femur, so probably not. A&E 5 is the distal portion of the quadriceps femoris. Yes, we discussed that. That's true. Unless if I have ventral divisions, I would actually think. Okay, femoral is posterior tilt. Okay, there we go. So I have no idea whether it's ventral or dorsal divisions. But okay, so yeah, I guess someone obviously knows that, so that's good. A is not the case because it's posterior divisions. I did not know that, so that's fine. But yeah, more of a simple question, not really deducting anything there, deducing anything there, sorry. I think this is the last question. Oops. Let's go back a little bit. A footballer sustained twisting injury to the knee during a tackle. A week later, he presented with symptoms of instability of the knee. Plain radiographs are normal. MRI revealed an anterior detail, blah, 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 blah. Which is the following test will be positive. Again, there are a lot of tests for MSK, like an unbelievable amount. But if you can, try and think about them logically. That can help you, I guess, memorize it. So we'll actually touch on these in a second, but first we'll just briefly go over the knee ligament injuries. So if I was to draw, again, forgive my bad drawing, but again, I don't know the exact positioning of the ligaments, but if I was to draw a knee here, if you understand the general positioning of it, you should be able to then deduce some more information about the injuries that can accompany them. So this is a anterior AP view of a knee, all right? I think let's say this is your right knee. This is an AP view. And yeah, we're pointing, whatever. Your lateral collateral ligament actually attaches to your fibula, I believe, and your medial attaches from your femur to your tibia. Okay, and if we take a side view, your anterior and your posterior ligaments, your posterior evidently comes from behind, your anterior comes to the front. And I'm sure there's some nuanced connections, but that's pretty much basically what happens. So logically, if you were to damage your medial, your MCL, what would you have to do? All right. One thing I want you to remember is to damage any of these ligaments, you have to pull them basically. You pull too hard and it breaks. So if I'm going to pull this ligament too hard, what am I doing? I'm going too far that way. Or, oops, sorry, too far this way. So basically a lateral blow to the leg would damage your MCL, I believe. Similarly, your posterior, say top posterior ligament, if you want to break it, you have to move your leg too far backwards. Okay. So there are a couple of examples here that might be useful to remember. Just to remember, have a good example just in your head. These are not the only causes, but it's a good thing just to have an understanding of what generally can happen to damage the ligament. So ACL, if you suddenly stop, all right, your ligament is going to be pulled forward. Sorry, backwards. Yeah, sorry, backwards. If you suddenly stop, you're in motion, you suddenly stop, you can imagine your femur kind of pulling backwards against your tibia, your ACL is going to tear. In a car, so my go-to for a PCL is a car accident. So if you think about it, if you're sitting there with your knee kind of up a bit and you crash, you know, your leg, your femur is going to go a little too far and pull on the. Sorry, it'll go backwards. So I mucked them up a little bit. Car accident. So this is a good way. This is a good reason why you should think about the the collateral ligaments and the cruciate ligaments with these examples, because obviously, evidently, I'm getting confused and flustered already. So in a car accident, what happens? You hit the dashboard, and your leg would go backwards, I presume, which would then pull on the posterior ligament. Okay, so for an ACL tear, you would have to go forward. Okay, so for an MCL tear, a lateral blow to the knee would mean you go that way. And for a medial blow to the knee to break the LCL would mean you go that way. Okay. So again, another way to understand the ligaments and try and memorize or understand what type of injuries or what movements would cause these injuries. And based off that, then you can start thinking about what tests are you going to do to sort of identify them. So anterior drawer test, right? you're drawing the knee forward, okay, which is similar to the injury that they've just sustained by pushing their knee forward. So you're going to obviously cause some pain. Posterior draw test, you're drawing the I guess femur in this case posteriorly. You're going to cause some pain. MCL, LCL, got your varus and valgus stress tests, which again, basically doing the same thing. Just you're pulling on the ligament in that certain direction. So I would recommend that you you can choose other examples, but I find for me personally, that you can see I was getting confused by trying to analyze it anatomically. But if I just remember these, it becomes a little bit easier to understand or to remember what injuries are going to cause, or what things you can do to cause damage to or cause injury to your ligaments. So yes, so that's that. So they're coming, no, hang on. Oops. It's one last thing, but I will just go back to that question for us. So yeah, for this question here, an anterior cruciate ligament tear will be the anterior drawer test. Now I will note, small point here, that the Lockman test is better. If they ask you in a question, what test should you conduct for an anterior cruciate ligament tear? Lockman is better than anterior drawer test, even though the drawer tests test for the anterior posterior cruciate ligaments and the valgus and varus test for the MCL and LCL. The Lockman is better for the anterior cruciate ligament. Now the patella tap sounds like a reflex thing, but actually I think it's for testing for joint effusion in the patella joint. It's not the reflex, but yeah, I think if you have effusion in your joint, that's what it tests for. All right, finally, so that's all the questions done. Finally, I just thought of a small high yield point to share with you, which is basically the femoral triangle. So of all the spaces to know, this is the most important. Again, logically, you can, instead of memorizing everything, you can think logically what passes through this area. You know, femoral nerve, femoral artery, femoral vein, anyway, or you can memorize them, that's fine. And there's a bunch of different acronyms. Okay, but the main thing that I wanted to bring up, and I'm not sure, because this is a sort of a point of confusion, but it is important to remember for next year as well, is a mid-inguinal point versus the midpoint of the inguinal ligament. So two clinically important things to remember. So I'm not sure if you've gone through this, but the mid-inguinal point, all right, and this is important. So we'll start off with the midpoint of the inguinal ligament. So the inguinal ligament is here. So the midpoint of that is going to be halfway. Right, so halfway between the aces and the pubic tubercle, which is where the ligament attaches to. So halfway through there, what's there? That's your femoral nerve, as you can sort of see here. Right, so the high yield point is midpoint of the inguinal ligament is femoral nerve. Again, you might have to memorize that, but you can logically think about, okay, well, what's going to be here? Halfway through the aces and the pubic tubercle. Now, as for the mid-inguinal point, that's what I've drawn here in this blue or this teal, which is from the aces, but a little bit further down to the pubic symphysis. Anyway, so it's going to be a little bit further down, and that the midpoint of that, so the mid-inguinal point there, or the midpoint of that line, is the femoral artery. So the femoral artery is the key point for the mid-inguinal point. Femoral nerve is the key sort of structure for the midpoint of the inguinal ligament. So clinically important things to remember. It's a bit of high yield content for you there, but yeah, just remember the distinction there. And again, you don't have to memorize all pubic symphysis, pubic tubercle. Just logically think about it. Where does the ligament attach to? Aces, pubic tubercle, yes. Right. So the midpoint of that will be a little bit further up compared to the midpoint of the mid-inguinal point, because that attaches further. Oh, doesn't attach, it's imaginary, but it kind of goes a little bit further. So which vessel, out of the nerve and artery, which one's going to be higher up? It's going to be the nerve, because the nerve comes out and innervates the anterior thigh, whereas the artery comes out a bit more medial. So logically, I would assume the femoral nerve would be a little bit higher. All right. So yeah, so hopefully that sort of clears that up for you. But yeah, that's basically all from me. Again, if you want the questions, I'll share the slides, but ultimately they just copied from the exams that you'll be doing later on. So yeah. If you have any questions, let me know. Otherwise, I will hand over to Don to finish you with the other lecture. Finish.
And actually, just before we start, maybe we'll give everyone like a 5-minute break, and we'll like start like 1:30. Oh, not 1:30, 12:30. So everyone, take a little break. But yeah, thanks, Raman. That was a really good lecture. Even I enjoy learning from Raman. Okay, yeah. But I guess we'll start with Don's lecture in 5 minutes. Yeah. So enjoy a break, guys.
Hey guys, how's it going? Can everyone see my screen real quick? Just chuck a thumbs up in that the chat, or yeah, just react. Okay, cool. So I'm done. I'm going to be going through NeuroPhys and MyoPhys. So I know this is probably like maybe going to be a bit dense. I tried to cut it down as much as possible. But I mean, one things to remember is like, this is probably one of the ones where you just have to keep like going over it. Like you might read over it once and it makes sense. But one of the things I definitely I did use last year was Anki to make sure that I'm remembering, the different pathways as well as muscles and, basically like pretty much all of NeuroPhys. Anki really helps with that. Now, you can feel free to give me a message rather than email, because I do not check my emails as much as I should. But yeah, anyways, getting on to it. Today we'll be talking about three main things. So first off, sensory system, then motor, and your autonomics. And also, guys, if you have any questions, just chuck it in the chat, and I'll have it up. So yeah, if I don't answer, just unmute yourselves and let me know. Fair warning, I will be asking you guys questions. So feel free, if you want to unmute yourself and answer them. If not, again, just chuck it in the chat. Perfectly fine. So a couple of useful definitions starting off. You might with, I shouldn't have put this weird little rant at the bottom. But anyways, this is probably something that would help you a lot, because I remember going into neuro and then it took me a while to understand, when they're talking about neuron and neuron and all those other things, they basically mean the same thing. Okay, so don't get confused. A couple of really important things, I think, are the contralateral and ipsilateral stuff, especially when they're saying where does it decussate, for example. It just means where does it cross over, on the same side or on the opposite side. So just a couple of things to remember. It can't hurt to know these. Now, with our nervous system, we basically have two main systems: the central, right, which consists of our brain and our spinal cord, and then our peripheral nervous system, or PNS, which has skeletal muscles under the somatic nervous system. And then we have the ones we're going to talk about today, mainly the sympathetic and parasympathetic systems, which are basically all the involuntary movements. So, the things that we don't actively think about doing, which is the way I sort of tried to remember it. Now, starting off with sensory systems. Just a quick overview. So sensation is, and I think you guys would have had Michael for this. He's a really good lecturer, but he sort of had a really good example with the tennis player. And basically sensation is the conscious or unconscious detection of stimuli, whereas the perception is our brain interpreting that information. So for example, distally, you might see, for example, an object, which is like a tennis player, whereas more proximally, the actual phenomenon, which is can't really pronounce words, which is the reflected light and then the sound waves, are detected by our sensory receptors. So our sensory neurons, they detect proximal stimuli, and then they convert it into our action potentials, which then go to our brain, and then our brain interprets it and passes it on. So quick things to remember: peripheral nervous system, again, is all about the sensation. It detects the stimulus. Whereas our central nervous system, it it's more about the perception. So that's where we start having the second order and third order neurons. Now moving on, basically the way information is transmitted is based off of these four things. So modality, location, intensity, and duration. So with modality, it's just the type of stimulus that we have. So what our brain does is it uses which pathway the information comes from to tell us, okay, what is the type of stimuli? Because if you think about it, right, our brain's sort of like, it's processing all this information. All the information is coming as an action potential, like, it's just like, it's a chemical release basically. So because it's the same chemical, same action potential, it uses the pathway to determine what are we sensing. So like the example here, the optic nerve receives information as light, right? But so technically, if you blow on the optic nerve, even though we can sense the blowing, what the optic nerve is going to transmit is that's going to be interpreted as a type of light. And I hope that makes sense. If that's confusing people, don't worry about, if that's really confusing, it just takes a while to sort of go over it. But yeah, just feel free to message me if that doesn't make sense. Now, with location, so where our stimuli are, and this we get from our receptor fields. So if we think about things like our fingers, right? We have a smaller sort of area. And so we have a higher spatial resolution. So we have greater accuracy. So if I have a pen, I have a knife, maybe this is not a good thing. But yeah, if I poke it, I don't know why I have a knife on my bed, but it's there. If you poke a knife here, I can actually pinpoint where it is. Whereas if you go into areas where there's lesser spatial resolution, like from memory, I think your thighs and those types of areas where there's greater area, you won't have as much accuracy, like the 2-point discrimination method, I think it was called. Now the second last thing is intensity. And intensity it's recorded in 3 ways. So the frequency, how many fibers there are, the frequency of firing, so how many times you're firing, the number of fibers, as well as the types of fibers. Are they sensitive or are they non-sensitive? Now, moving on to duration, there are 2 types of duration. There's phasic, where you generate the burst when action potential is first stimulated, whereas tonic, where you're sort of gradually increasing, or you generate the impulses very steadily. So it's like sort of going off and off and off. But yeah, any questions so far on that stuff, guys? Okay, cool. Now, with our somatic sensations, there are 3 things. I should have checked that typo. The mechanoreceptors, the thermoreceptors, and also proprioception. Now, one thing I think that's really important to distinguish is between mechanoreception and proprioception. Like mechanoreception is the actual external stimuli, and we'll talk about this in a bit, but it's actual like your reaction to external stimuli, like picking up a phone or a water bottle or something like that. Whereas proprioception is like basically where our muscle is or where our hand is. That's what proprioception is sensing. So with mechanoreception, we have 2 types of skin, right? Our hairy skin and glabrous skin. And like your glabrous, like on the diagram, is more so where you'll find things like the Merkel cells, sorry, I can't really pronounce these, but Meissner corpuscles and stuff. And these are the sort of 4 mechanoreceptors we have. So the Meissner's corpuscles, Merkel's Pacinium corpuscles, and Ruffini's corpuscles. I probably butchered those spellings, but there's that. But anyways, and I think one really important thing is the structure of these mechanoreceptors determines the function. And what function it has determines where it will be placed. Is it more proximal to the skin? Is it more deep to the skin? Sorry, superficial or deep to the skin. This was a great table I found of PS Platypus. They did a really good job here in sort of giving you a quick sort of rundown on what these different things are. So our two main slow adapting or tonic mechanoreceptors are the Merkel cells and Ruffini's corpuscles. Now they're usually found in the upper dermis and dermis, and you can see that like with each slow adapting and fast adapting, we have a big difference between something that has a small receptor field, which means it will have a high resolution. So there'll be a lot of Merkel cells around density wise. Whereas with the larger receptor fields, we have low spatial resolution. And so the density will be more like where we'll find the cells will be more spread apart. And it goes again to reiterate that message at the start, which if I can go back and find it, about the whole idea about location. Now, and yeah, whereas on the other hand, you have the fast adapting, and it's the same sort of process. You have the small receptor field, which means you have high spatial resolution, high density, and the opposite happens for the Pacinian corpuscles. Now, it's very, like in terms of what's going to be high yield out of this, definitely the receptor fields, and also like the sensitivity it has. Because if you think about it, if we are looking to sort of, or like, you know, the function of pattern, shape, texture. So when we're feeling things, we want to have a very, we want to know, like, you know, what we're holding. Like, for example, are we holding, again, I don't know why there's a knife on my desk, but trust me, it's not like anything bad. I just think I had it lying around. So, you know, I'd rather grip like the handle rather than the blade. So I want to know what I'm holding. So that's why you'd want to have that high density. And yeah, any questions at all, guys? Yeah. Anyways, moving on. Now, with thermoreception, there's really not much to know with it. It's just the two different fibers we have. And, you know, we can sense heat and we can sense cold. So the two fibers we're going to have are warm fibers, which will detect our warmth, you know, things over 25 degrees. Whereas cold fibers will detect, you know, cold temperatures. Now, what do I mean by greater, like, you know, a lot of amount more than warm fibers? We actually have a lot more cold fibers than we do warm fibers. So we'll be able to detect colder temperatures, I guess, quicker and better, and respond to it faster. And like it says here, the fiber firing rate is proportional to temperature change. So as you increase temperature, your fibers are going to start firing faster and faster and faster, because like, and this sort of touches on pain a bit, which we'll get into it in a second. But if you think about it, you know, we don't want to leave our hand over a fire for like 5 minutes for them to be like, you know, after 5 minutes, be like, oh, cool, it's too hot, let's move it away. Like, you know, as soon as it gets really, really hot, it's a protective thing where we want to quickly sort of move our hand away. And it's the same thing here. So, and it goes both ways, you know, if you get dipped into the Antarctic Ocean, I don't know why, but let's say it happens, right? Your cold fiber will go off, because it's telling you, okay, get out of the cold water, let's try and warm ourselves up. And your body will do a lot of other things to try and warm itself up as well. But yeah, that's probably one of the most important things to remember with thermoreception. Yeah, and if you guys have any questions, again, just chuck in the chat. But yeah. Now, with proprioception, there are two main sort of receptors that we have, which is the muscle spindles, which are found in the belly of the muscle. And these are basically stretch receptors. So it will check if we have different changes in length. So are we contracting? Are we extending? And basically they fire, or stretching, sorry. They basically fire when they're stretched. So the 1A sensory neurons, whereas the Golgi tendon organs, like it says, tendon organs, so it'll be located in the tendons. And it's sort of like a protective thing, because it responds to increased tension. And we don't want to sort of rip apart our muscles, and we don't want to, you know, basically break our muscles, right? So what these 1B sensory neurons do is they send information if tension's changing too quickly. Because at the end of the day, the attachments that our muscles make to our bones, they can come under a lot of stress. And if they come under a lot of stress too quickly, we might end up hurting ourselves. So that's why we have these tendon organs as well. Any questions at all, guys? Cool. Now, on to pain. And I think pain is probably one of the more high yield topics out of the sensory stuff. You have your mechanoreceptors, but this is probably going to be the next big thing that they're going to test. Because I don't know if you had these lectures yet from Richo about pharmacology and analgesics and stuff, and that all links in with pain. So I haven't really focused on the pharmacological side here. I've just focused on the physiological side. But like I said earlier, pain is a protective mechanism. So, and the receptors that we have, or the fibers, are free nerve endings. And they're polymodal, as it says here, because they respond to a large range of stimuli. And you can imagine, there's a lot of things that can hurt us, like, blunt objects hitting us, a knife, for example, or like the heat, the cold, a lot of things, right? So it's our body's way of telling ourselves, us to get the hell out of that situation or do something to change it. Now, there are 4 phases. So transduction, where the stimuli, the noxious stimuli or whatever stimuli we have, they activate the nociceptors. The transmission phase, where the pain from wherever it's being sensed gets transmitted to the sensory cortex, and it's via this sort of pathway. And so I don't know if I'm covering this later, but basically this pathway is this, what it's called now. I think it's the anterolateral spinothalamic tract. It's very different to the DCML, which is something you guys would have covered last sem. And the difference is basically that pain receptors or pain transmission, it decussates, so it crosses sides at the level of the spinal cord. It won't, so unlike the DCML, it won't be at the medulla, it will be at the level of the spinal cord. So, and then we have the modulation phase, where we have the descending pathways inhibiting signaling. And then finally perception, where if we're burned or something, we become conscious to that pain. Now,
wait, Don, did you say that anterolateral spinothalamic decussates at the spinal cord rather than?
Yeah, I'm pretty sure that's the name. If I can I'll change it. I'll add it in afterwards to this slide. Don't hold me as a fact to that. I think it's anterolateral, but I'm not 100% sure of the name. But I know it's this, it's to do with a tract, because I have a question about it later.
Thank you.
Really sorry about that, man. But I'll do a quick cheeky Google on the side. There's 2 important chemicals in terms of transduction. So we have histamines, right? And I'm going to butcher this. Eicosanoids, okay? So our histamines, they activate nociception. So they activate the receptors. They activate the fibers, and they're released from our mast cells. Whereas our crap. You guys know what I'm trying to say. They sensitize pain. So what this means is the channels will be open. This is done via the leukotrienes and prostaglandins, and these are usually released from damaged cells. Now, probably this bottom part about thermoreception, I don't know if Raman and Bibi can add to this, but I remember it was mentioned in the lecture, but it definitely wasn't it's probably pretty low yield. But yeah, just for your knowledge, TRPV1 is for burning temperatures and TRPM8 is for freezing temperatures. But I really think it's not that likely to come up on your exams. Now, with transmission, we have 2 types of pain. I don't know why that's repeated again. But the 2 types are fast pain and slow pain, where fast is transmitted via the A delta fibers, and these are small and myelinated. So what does small and myelinated basically mean? Myelinated is basically like it's going really fast. So if you have an unmyelinated nerve, it's going to be slower at transmission. Okay. And this means that this type of pain is well localized. So, you prick yourself with something that will be going through your A delta fibers. Whereas our slow pain is transmitted by our C fibers. Now, there are all these different types of A delta and C fibers. Again, that was probably not, you can remember all four of them, but I think it's better to understand, what's the difference between fast and slow pain, because the questions you're probably going to get are like, someone has gone out and like hurt themselves doing this. What's the first type of thing that they, what's the first sensation that they have? How's that transmitted? Rather than asking about the individual sort of types of fiber. And yeah, our C fibers are fully localized. So like the diagram down here says, the first pain will be from A delta, whilst the second pain will be from our C fibers. Now, yeah, and this is credit to PS Papa, which they had a really good slide that had it about all the fiber size, type, and myelination. And I'm pretty sure this would have been on one of your lectures too. But really important thing to remember, our large, right, myelinated alpha and beta fibers, they're for discriminative sensation. So if we're looking at, picking up things or, picking up things or, sensing where our hand is, for example, those will be our alpha beta. And if you think about it, right, we want those fibers to be pretty heavily myelinated, because then that means that we're getting that information quicker to our brain so that we can perceive it quicker as well. Whereas our small myelinated fibers, so these two, right? Sorry, the delta one. They're more for again, non-discriminative sensation, like pain is non-discriminative. And yeah, and this is like a nice diagram on the different types. Like again, you don't need to know the diameters. You don't really need to know the stuff about autonomics. It's probably just better to remember alpha beta. They're probably going to be they go via the DCML pathway, whereas delta C and all that come through the spinothalamic. Now, with modulation, what basically happens is as we sort of get our pain going up to our brain, we also have a descending pathway that ends up inhibiting ascending pathway, creating an analgesic effect. And these effects will be seen at the level of the spinal cord. So the way it follows is you have an input from your cortex and your thalamus, and they converge at the, I'm just going to use the initialization, the PAG. And then this descending pathway synapses to inhibitory interneurons. And these inhibitory interneurons release enkephalins, which inhibit the transmission from afferent fibers. So as we realize, we have this pain transmission going up, we release the enkephalins to inhibit that afferent fiber transmission, which can be seen in that diagram there. And yeah, so this is probably a good diagram that outlines, both of the ascending pathway and the descending inhibitory pathways, where basically you come here, you cross at the level of the spinal cord, and you go up all the way, and then after that, you come from the PAG down to the level of the spinal cord, or you'll have the release of enkephalins. Any questions at all, guys? Cool. Now, perception, yeah, like I said, is reliant on the spinothalamic tract. So that means it decussates at the dorsal root. And the pain that we have can either be somatic or visceral. So visceral, the way I remember it, think organs. And this stuff will become like second nature to you guys. Cool. I'll get to that question at the end. But yeah, so pain can either be visceral or somatic, right? And somatic will be like, like a pain in your thumb, for example, whereas visceral will be something like a pain, like, a deeper pain with the organs. And usually it's this visceral pain that is then referred to the somatic areas. So for example, a common thing, if someone's having a heart attack, or there's some sort of chest pain, it's usually referred to your left arm. And you might also get shoulder tip pain from, and when you guys learn about it's like the diaphragm, you'll get shoulder tip pain from that as well. And we have 3 basic explanations. And these are all theories as well, because we don't really know what's happening. Well, we can sort of know. But the first one is common dermatome. So that the pain refers to structures. So if you have the same embryonic segments, and embryonic basically means don't know how much of embryology you guys have covered. They're deriving from the same areas. So for example, our diaphragm, it's another organ in your body, not organ, muscle sort of. It's sort of derived from C3, C4, C5. And the way I remember it is like Michelle, she has like a really nice way of remembering it. But basically, any sort of irritation in the diaphragm you might feel in the C3, C4, C5 areas. Convergence hypothesis is basically where branches of the visceral pain fibers synapse to the same second order nerve. So because you have basically this, like whatever organ, it'll be conducted through the same neurons as another pain signal that's coming from the skin. And so the person will feel that pain from the skin rather than from inside. Now, someone asked, do we need to know the specific locations of referred pain? Probably not, not at this level, for NeuroPhys at least, but definitely when you guys do cardio and all that, you will, when you guys do cardio and stuff, it'll just be under the pathology and clinical stuff. C3, C4, C5, that was for the diaphragm. So that's what keeps the diaphragm alive, essentially. So C3, C4, C5 innervates the diaphragm. And then the final one's the learned phenomenon, which is basically where the visceral information arrives in the CNS, but our brain interprets the origin from like a previous trauma or injury. So I think that's where you get into the sort of phantom limb stuff, but we don't cover that today. Now, this might be a familiar thing that you have seen in first sem, the gate control theory, or basically our C fibers excite the second order neurons. And so the A beta will excite inhibitory interneurons. And so you'll inhibit the second order neuron. Now, these A beta fibers, neurons, carry information from the mechanoreceptors, and the activation of this will inhibit the transmission of pain. So that's why, if you're feeling a pain in your arm or something, you can rub it, and that sort of, in the sort of mechanoreception will then sort of activate an inhibitory interneuron, which will then inhibit the transmission of pain. Okay, cool. Now, some questions. So I kind of need you guys to respond. Just chuck it in the chat. You can direct message me. So where does the tract carrying vibration and proprioception decussate? Yeah, so it's going to be the medulla, because that's your DCML pathway. Whereas at the spinal level, that will be sort of pain and pain and those other sensations. Now, like I said, this is probably what's going to be more like an exam type question that you might get, which will be like, a boy cuts his finger with a pocket knife and immediately applies pressure to the damaged area. Now, inhibition of pain signals by tactile stimulation of the skin is mediated by which type of afferent neuron? Yeah, it's going to be B again as well, because remember, beta is mechanoreceptors. So tactile stimulation will be your mechanoreceptor, receptors, which is why it's A beta and not going to be A alpha. Now, yeah, you might get tricked by the fact that it does talk about like some sort of injury, but remember, make sure you look out for things like that, like what they're talking about and what they're asking about. Now, I think this is the last question, but which of the following is false? Yeah, it's going to be C. So pain perception relies primarily, B. Yeah, B with the C fibers, yeah. C fibers have a wide diameter and are heavily myelinated. And if you just go back one slide, remember, C fibers, they don't have a wide diameter. They're pretty small and they are not myelinated at all, okay? So that's why it's going to be B. Cool. I'll come back to the question about the periaqueductal gray matter. Someone asked basically, what's the significance of the periaqueductal gray matter? I think at the moment for this stuff, I think it's just the pathway where it starts. So I don't know, I can get back to you on it, the significance, but for the moment, I think the most important thing for you guys is to just know the pathway and what happens down the pathway. So, you know, what gets released like encaphalins. And this is basically also where opioids and the sort of from the pharmacological aspect, your opioids end up acting at this voltage gated channels as well, where they, you know, inhibit in the same manner. So that's how your analgesics work. But yeah, in terms of the periaqueductal gray, for the moment, it's just know that the inputs from the cortex and the thalamus converge at that place. There's no real need at the moment to know the significance, but if you really want to, I'll have a look into it and I'll send you a message afterwards. But yeah. Cool. Now, with motor systems, so we have our central nervous system, which receives the afferent signals, and then it then sends out efferent signals to the spinal cord. Okay, and our brain has these two main sort of components: the cerebral cortex and the cerebellum. And we have I'm not too sure how much of this you guys have covered, but we also have in the cerebral cortex the primary motor cortex, where it's organized contralaterally. So if you remember from earlier, it just means that everything's on the opposite side. So the movements on my left-hand side, they're controlled by the right side of my brain. And also the most important, not most, but like the thing to remember is the amount of cortical space that we have in our brain, in the primary motor cortex, is proportional to sensitivity. So what you'll find is in very sensitive areas, and this is outlined really well in the homunculus map, what we find is that the bigger the sort of like the cortical space, the more sensitive those regions are. Like for example, your face has a really big area, whereas I think your limbs have a proportionally smaller area. Then you have your premotor cortex, which plans the action, and then your primary somatosensory cortex, which receives the information. And then your cerebellum, so at the bottom of your brain, it modifies the efferent signals, so it sends out those signals. Now, yeah, I realized this morning that some of my slides just did not have any like pictures, and I tried to be creative, but I don't know. Yeah, so if there's something funny, like laugh, I guess, but if not, it's okay. So with movement, yes, of course, I know it's weak, but excitation is the stimulation by neurons. So remember, thinking back to Sem 1 when we did the whole stuff on action potentials. Whereas the contraction in our muscles is the interaction between actin and myosin. And actin and myosin are your main players when it comes to muscle, like skeletal muscle contraction. Okay. Now, I've sort of broken up excitation and contraction into 3 different slides. So the first thing happens at our neuromuscular junction. And this is where our action potential will travel down to the motor neuron. and ACH. So ACH is acetylcholine, and it is released and binds to receptors, and this will cause an influx of sodium ions at the motor end plate. So sodium ions are very important when it comes to the excitation part, and this is where opioids and those types of analgesics come in, is they block these voltage-gated sodium channels so that you can't actually get that. Oh, sorry, no, this is talking about something different, but it's basically a similar thing. Not when it comes to excitation, but when it comes to analgesics, it sort of works like that as well. Now, at the actual muscle, we'll have the action potential coming across through the plasma membrane, right, to the voltage-gated DHP receptors. Now, these receptors will open another receptor called a ryanodine receptor. And that ryanodine receptor stimulates the sarcoplastic reticulum to release calcium. Now, once calcium's released, we'll have cross-bridge cycling. So just to give a bit of context, so when we're at rest, the actin is blocked. So if you sort of think about it as like a cap, by tropomyosin and troponin. And this and myosin is unbound, but it's energized from ATP to ADP plus the inorganic phosphate. Please know what they mean. Like ATP is ATP, ADP, and the inorganic phosphate, because these are the three important things that will help with our cross-bridge cycling. So once our calcium is released from the sarcoplastic reticulum, it binds to the troponin. Now, what that troponin does is it pulls the tropomyosin away. So it pulls off the cap, basically, and exposes the myosin binding site. Now, myosin then binds the actin, and that's when we sort of have the cross bridge. And if we sort of go to the picture, it's sort of all done around here. Now, then we have the power stroke, which is essentially where the myosin head will sort of come around and it rotates. It'll release this ADP plus the inorganic phosphate, and then your actin strand gets pulled along with it. Okay, and this is where your sarcomere will contract. Now, after this contraction, your ATP will bind to myosin. It will break the cross bridge that was there, right? And then it's split again, re-energizing the myosin head. And the last sort of step, it's sort of like a continuous thing. So the last step is your calcium, ATPase pumps the calcium ions back from the cytosol. So all this calcium that's been released, it'll pump it back into the sarcoplastic reticulum. And what it does is it does this to maintain the concentration gradient, right? So like we go through here, right? So you bind your myosin to actin, then you have sort of you have the pulling away, and then afterwards the sort of power stroke. Then you have the new ATP, which then unbinds and recocks the myosin head. Now, this will be really important when it comes to a couple of high-yield stuff that we'll talk about in a little bit. I'll just sort of flag them. So one is rigor mortis. That's like the main thing when it comes to like this sort of idea of cross-bridge cycling and why does that occur. From memory, that was something that was asked. Now, before we get to that, just the types of contractions. So we have two main types. So we have isometric. So it's like, you're creating a force, but your muscle length doesn't change. So you're not actually like sort of moving your arm up and down, right? And that's, I think, the best way to remember. And then we have isotonic, where your length and your force, where you develop a force and your length is changed. So we have two types of isotonic, contractions. We have the concentric, so bringing sort of like a weight up to your, I think the best example is a bicep curl, but bringing your weight up, and then your eccentric, which is sort of letting it down. Okay, because you're still having a force, but you're in the eccentric, your muscle's lengthening as you're producing that force. Okay. Now, the length tension relationship. Again, this is something that you can do with sort of the bicep curl. It's basically that at certain points, you have the optimal amount of strength that's coming out, right? So depending on how stretched out or how contracted your muscle is, you will have the amount of force that's generated. So I've tried to match up the numbers pretty well. So with one, so this area here, we have a less than optimal length. So basically, you can know about the thin filaments, the overlaps and stuff, but the way I sort of remember it is you have less force generated upon contraction. Like, it's very hard to bring that up. Okay, yeah, Susan. So I'll get up to that rigor mortis stuff in a bit. Don't worry. So second one, optimal length. So this is sort of when your muscles, like, I guess, like, pretty much 90 degrees, I guess, where you have the maximum amount of force. So if you ever try a bicycle, sort of get to a point, it's actually really easy. And so the hardest part is actually if you cock out your arm straight and trying to pull it up like that. And then you have the greater than optimal length, which is over here, where it's all the way, like, too far contracted, and you're not really going to get any force out of that. Okay. Now, yeah, so this is the sort of exam type questions you're probably going to get, all right, is about rigor mortis. So as we all know, ATP is required for the detachment of the actin and myosin, right? So the detachment of the myosin head. So after we die, right, there's no ATP unless we become zombies or whatever. I never thought about that, but no. But with no ATP, right, our actin and myosin, they remain locked. And because when they're locked, you'll have a stiffer body, which means rigor mortis, right? So you don't have that detachment of the actin and myosin. So that's basically the whole rigor mortis stuff that I was going on about a little bit earlier. Okay. Now, another important pathology is myasthenia gravis. This is something I think that will come up a lot throughout the rest of your degree. Like, we get this mentioned in some of our stuff this year as well. So if you it's very easy to remember. It's an autoimmune destruction of the acetylcholine receptors. So what ends up happening is, if the receptors have been destroyed, right? And it's usually because we have an increase of acetylcholinesterase, which basically is something that blocks the transduction of the signal transduction in the NMJ. So what our treatments are, we treat the patient with anti-acetylcholinesterase. I don't think the treatment's really necessary here. Just know that myasthenia gravis is the destruction of the receptors. It impairs the signal transduction. So then that way, the features that we'll get, the clinical features, is someone will present with muscle weakness and fatigue. So, when you don't have the capability to actually send a signal out. Okay, so this is probably the most important part. The treatments are sort of, I don't think there was really that much high yield in year one. Cool. Now talking about the autonomic nervous system. The autonomic nervous system, it maintains homeostasis, so the normal processes in our body, right? And they have an intrinsic activity, and the innervation modulates it. So think about our heart, right? We're not telling our heart, okay, beat at 60 beats per minute, and or even our gut, we're not telling it to digest at this rate or go and digest. Whereas with our skeletal muscles, for example, we're actually moving them about, right? Now, the autonomics can be split into two, and this is where it gets really annoying because there's so many divisions, but you'll get the hang of it by the end of it. So sympathetic is our fight or flight, right? And parasympathetic is rest and digest. I really recommend just drilling this into yourselves now. It's very easy to remember, but if you know this, it will help with, when we get to it, the effects that our sympathetics have on certain organs and the effects that our parasympathetics have on other organs. So again, thinking about my example, the heart, right? So fight or flight. So what do you think will happen when we're, there's a lion coming out at us? We're probably gonna, we're gonna increase our blood flow because we need to run, right? Whereas let's say we're just, maybe right now sitting at home on Zoom or from YouTube, whatever, your parasympathetics are probably activated. You're resting and sort of digesting, right? Now, these systems, they have a circuit with two neurons. It's very simple, preganglionic and postganglionic. The preganglionic is myelinated, so they're pretty fast, and the postganglionic is unmyelinated. Now, just to touch on the somatic nervous system, it's very highly specialized, right? And it's what makes our muscles contract. So it's our voluntary sort of nervous system. Now, this is like a very pretty detailed, I guess, overview of what happens. What are the bodily organs? What's its normal functions, and what the effects on the sympathetic, and what are the effects of the sympathetic and parasympathetic nervous systems? I think the ones to highlight the most, I'll quickly get my annotate thing, are probably going to be your pupils, heart, and intestines. Those are probably the main ones to know. You can also go for bronchioles of the lung as well. Those are probably the most important ones out of them. Please don't go around and memorize all of this, right? It's really it's better to try and understand what's happening, and then that way you can think of it pretty broadly. So pupils, right? So for example, if we're in our sort of fight or flight mode, we're going to dilate them because we want to see more. And whereas in the parasympathetic, they're going to contract, right? And you can sort of work through this table. Now, with the parasympathetic, and this is sort of with the neurotransmitters and stuff, best diagram by far is probably this one. It does have a little bit extra information, but what I used to do to try and memorize it was basically just draw something simple. I'm not a very good artist, but I just draw like a line and be like, okay, somatic nervous system, myelinated all the way through. Sympathetic, we have preganglionic. We have our preganglionic shorter and our postganglionic a bit longer, right? And parasympathetic, preganglionic longer, myelinated, postganglionic shorter. And that's basically what I've summarized here. Now, it's very important to know what happens at the ganglions and at the target organ in terms of the synapses. So at the ganglion for parasympathetic, our neurotransmitter is acetylcholine, but our receptor is a nicotinic receptor. At the target organ, our neurotransmitter is acetylcholine again, and our receptor is muscarinic. And these, the sort of parasympathetics, exit at the level of the brainstem and the sacral portion, so from our craniosacral area. Whereas our sympathetics, like I said earlier, the preganglionic is shorter, and the synapses are cholinergic and adrenergic. What I can do, I remember I have like a set of detailed notes, I think I do at least, out there. If I find it, what I'll do is I'll chuck it onto the, I think you guys have a folder where you have all this stuff there. But I think from memory last year, we got like this like PDF, and we had to sort of get out the information by ourselves. But if it helps, I think I have a decently worded way of remembering the stuff that's in those notes. But I'll chuck it up or I'll get Ruby to chuck it up or something. But yeah, at the ganglion, the neurotransmitter is acetylcholine, the receptor is nicotinic. At the target organ, neurotransmitter is noradrenaline or norepinephrine. Those two things are used interchangeably. And our receptor is either an alpha or beta receptor. These nerves exit from the thoracic and lumbar region, so thoracolumbar of the spinal cord. And yeah, this is a very nice diagram that summarizes most of that. Now, this is probably the more important table to remember. And it's basically, with the receptors and also what does it do. So, so in the eyes, right? If we activate the parasympathetics, will cause miosis, which is pupil contraction via the muscarinic 3 receptors, right? Or the M3 receptors. Whereas the sympathetics, we will cause dilation via the alpha 1 and the beta 2. Okay, but the main ones to remember, again, I think heart and lungs, they are very common to be asked. Like more from a pharmacological perspective when you guys do cardiac, rather than like a NeuroPhys. But it still helps to know what receptors do what, so that okay, if I give this type of this type of medication, what will happen? Okay, definitely something to commit to memory. Now, on to questions. Okay, so a 60-year-old dude has a lung tumor that is compressing the sympathetic ganglia, which contains sympathetic fibers to head and neck. So what do we think will happen? Okay, and you guys can look through the previous slides as well. Meiosis and decreased sweating. So it will be meiosis and decreased sweating. So we will have a dilation of the pupils and decreased sweating. So this is a very common pathology, as in it's something that I think gets asked for days. Like it's on everything. It's called a pancoast or apical tumor. I think Booby had a question about this earlier as well. But in terms of the nerves, right? So sweating. So normally we get increased sweat production via the M3 receptors. So if we knock that sympathetic out, we're going to get decreased sweating. For the eyes, we normally have dilation and increased production via the alpha 1 beta 2. So instead, we'd get the parasympathetic effects because we're knocking out the sympathetic effect. Okay, so that's the way to remember that. Now, that's pretty much it from me, guys. Thanks for staying, I guess, alive during this one. If you have any questions, again, please do text me or chuck a message on Facebook, or send me an email if you really want to. But yeah, thank you. If you guys have any questions, just stay back. But if not, I'll pass back on to Booby. And yeah. If Booby's still there.
Okay, thanks, Don. There's like 10 of us left, but it's nice to see you guys make it to the end of all the lectures. Okay, so since there's only 15 of us, I just wanted to ask you guys, do you guys want, so Raman is set to do a little Kahoot, just on the anatomy stuff, but if you guys want, he's happy to do it some other time, later tomorrow even, if it's more convenient, because obviously we've had 3 hours of just speaking, so must be a bit tired. So if you guys let me know, just I guess give me your reactions, a thumbs up if you want to do the Kahoot now. If you guys are way too tired, we can do it later, perhaps tomorrow. So give me a thumbs up for now, otherwise give me nothing for tomorrow. Okay, well, we got 3 thumbs up, I think. So we'll make that a tomorrow thing. So I'll make another Zoom, I'll make another post on the Facebook group page, and I'll get Raman to do the Kahoot tomorrow. And yeah, with the timing and stuff. And as always, the recording will go up on YouTube, slides will go up, or are up, so if you guys want to look back at it. But yeah, feel free to shoot any questions in general. If there's any issues in general as well with you guys in year 1, let us know. Hopefully we can try and make it better. But yeah, thanks for sticking with us for these 3 hours. Enjoy the rest of the semester, guys.
Thank you.
Thanks for organising it, Moot. Love you.